And close laptop. We'll start over here, right? Just started. For 1 2 minutes, let the students show. You have to wait for a minute or two. So they get your glass of water or something. Meanwhile. Light for a pendulum, what are the fun? Check with me. लेकिन एक पेशेंट है मेरे को 2 मिनट के उसको देखने जाना हो yeah and she's not so okay I'll ask her to start.
So, very good evening to all of you. Good evening. Am I audible? Am I audible and screen is visible? So, today in this video, I will be discussing important points of obstetrics. Okay. So, ऑब्स में जो भी important points है मैं just वही discuss करूंगी इस वीडियो में. Okay. So, start करते हैं. First topic, that is early signs of pregnancy on ultrasound. Yeah, good evening to all of you. Maybe session रहेगा maybe 2.5 or 3 hours. Dr. Imdad, yes, maybe 2.5 and 3 hours. So let's start with the first topic, that is early signs of pregnancy on ultrasound. So you can see clearly ultrasound image. So first one is the due to formation of gestational sac. So what is the sign? ये कौन सा sign है? Due to the formation of gestational sac. This one is the first sign of pregnancy. First sign of pregnancy on ultrasound. Yes. So you can see clearly this one is the gestational sac. So intradecidual, this one is the intradecidual sign. Intradecidual sign. The first sign is intradecidual sign. So second one, in second image, you can see two rings are formed, inner and outer ring. Two rings are formed. First one, inner one is decidua capsularis, and outer one is decidua paritalis. Second one is decidua paritalis. So ये कौन सा sign हुआ? Second one, that is double decidual sign. Double decidual sign of pregnancy on ultrasound. Yes. And the third one you can see gestational sac. This one is the gestational sac with two bubbles. So due to the formation of yolk sac and amniotic sac. So what is the name of this sign? Yes, anyone? So this one is double. This one is double, yes, bleb sign. So double bleb sign. So clear to all of you? First sign is intradecidual sign. Second one is double decidual sign. And the third sign after the formation of yolk sac and amniotic sac, that is double bleb sign. So next one is amniotic fluid. So what is the source of amniotic fluid? So first trimester में source क्या रहेगा? Ultrafiltrate of maternal plasma from placenta. 12 to 20 weeks पे fetal skin and after 20 weeks fetal urine. जो main contribution रहता है वो रहता है fetal urine का. So first trimester ultrafiltrate of maternal plasma from placenta. Then 12 to 20 weeks fetal skin and the third one is after 20 weeks क्या रहेगा? Fetal urine. So fetal kidney start producing urine by, yes, fetal kidney start producing urine by 12 weeks. By 12 weeks. Amniotic fluid is maximum at 30 to 34 weeks. Please remember this point. Amniotic fluid is maximum, means up to 1000 ml at 32 to 34 weeks. So next point is measurement of amniotic fluid. हम amniotic fluid को कैसे measure करेंगे? So investigation of choice is ultrasound. Ultrasound. So in ultrasound, we will divide the abdomen into four quadrants. A, B, C, and D. Okay. Then we will check the two parameters. One is amniotic fluid index and the second one is single deep pocket. Amniotic fluid index and the second one single deep pocket. These are the two parameters for amniotic fluid measurement. So normal AFI, values of normal AFI 5 to 25 centimeters and the single deep pocket 2 to 8 centimeters. These are the normal values of AFI and SDP. So next one, what is oligohydramnios and what is polyhydramnios? So in case of oligohydramnios, if the amniotic fluid index is less than 5 centimeters and the single deep pocket less than 2 centimeters is a diagnosis for oligohydramnios. Yes. So volume in case of oligohydramnios less than 200 ml and the fundal height will be less than period of gestation. So ये हुआ oligohydramnios. In case of polyhydramnios, if the amniotic fluid index is more than 25 centimeters and single deep pocket more than 8 centimeters. तो यहाँ पे diagnosis हो जाएगा polyhydramnios का. So volume in case of polyhydramnios more than 2000 ml and the height, fundal height will be more than period of gestation. So ये हुआ differentiate between oligohydramnios and polyhydramnios. So what is the most common cause of oligohydramnios? So yes, what is the most common cause of oligohydramnios? Anyone? That is fetal renal agenesis. Fetal renal agenesis. And the most common, yes, Dr. Dinesh, right, renal agenesis. And what is the most common cause of polyhydramnios? That is cross congenital GIT anomalies. Then neural tube defects. So most common cause of oligohydramniosis, fetal renal agenesis. Yes, and the most common cause of polyhydramniosis, gross congenital GIT anomalies, then neural tube defects. So one important point, what are the consequences of oligohydramniosis? So इस पे कई बार क्वेश्चन आया है. Okay, so Potter syndromes. Please remember the name of the syndromes: amniotic band syndrome and meconium aspiration syndrome. So Potter syndromes में क्या होगा? Pulmonary hypoplasia. Pulmonary hypoplasia, amniotic band syndrome, and the third one is meconium aspiration syndrome. These are the consequences of oligohydramniosis. So next one, prenatal aneuploidy screening. This one is very important topic. Prenatal aneuploidy screening. So first trimester में हम कौन सा टेस्ट करेंगे? So in case of Down syndrome, screening for Down syndrome, first trimester, first one is double marker. Double marker में we have beta HCG and TAP A, pregnancy associated plasma protein A. इनको कहते हैं डबल मार्कर्स. एंड साथ ही हम करेंगे अल्ट्रासाउंड. अल्ट्रासाउंड में we will check at the nape of the neck soft tissue thickness, that is called as knuckle translucency. It should be less than 3 mm. Yes, and nasal bone, and we will check the presence of nasal bone. Nasal bone. So in case of Down syndrome, if the values are more than 3 mm and if the nasal bone is absent, तो diagnosis क्या हुआ? Screening क्या हुई? Down syndrome की. So ultrasound में we will check the knuckle translucency. It should be less than 3 mm and presence of nasal bone. और इन दोनों टेस्ट को हम कहते हैं combined test. Combined test. Combined test. So these are the first trimester test, 11 to 13 weeks. These are only screening tests. So in second trimester, 16 to 20 weeks, 16 to 20 weeks, triple test and quadruple test. Yes, Dr. Rahul Tiwari, I will share the PDF, sure. So triple test, beta HCG, maternal serum, alpha fetoprotein and unconjugated estriol. So these are triple test. कब करेंगे? In second trimester. And quadruple test, all three tests plus inhibin A. So these are called as quadruple test. So next one is cystic hygroma. So what is cystic hygroma? This is a lymphatic swelling. Lymphatic swelling. You can see in this image, ultrasound image, this part. Lymphatic swelling. This is called as cystic hygroma. So what are the causes of cystic hygroma? Causes of cystic hygroma. First one is trisomy 21 and the second one Turner's syndrome. Turner's syndrome. So most common cause of cystic hygroma, trisomy 21, and the second most common cause is Turner's syndrome. If aneuploidy is absent, means यहाँ पे डाउन सिंड्रोम भी नहीं है, टर्नर सिंड्रोम भी नहीं है, then cause क्या हो सकता है यहाँ पे? Congenital heart disease, fetal congenital heart disease. So best बेस्ट टेस्ट कौन सा हुआ फॉर द स्क्रीनिंग ऑफ डाउन सिंड्रोम? दैट इज NIPT. NIPT, नॉन इन्वेजिव प्रीनेटल टेस्टिंग. नॉन इन्वेजिव प्रीनेटल टेस्टिंग डन एनी टाइम. इसको हम कभी भी कर सकते हैं. सैंपल क्या होगा? सैंपल विल बी मैटरनल सीरम. मैटरनल सीरम. एंड एनालिसिस क्या करेंगे हम यहाँ पे? सेल फ्री DNA testing. Cell free DNA testing, and sensitivity is 99%. This one is the best screening test for Down syndrome. But this test is very expensive. Very, very expensive. But this one is the best test for Down syndrome. So in case of Down syndrome, remember the mnemonic high. हाई मीन्स डाउन सिंड्रोम में हमें मिलेगा रेज्ड बीटा HCG एंड रेज्ड इनहिबिन. So in Down syndrome, raised beta HCG and raised inhibin. So these are the screening tests for Down syndrome. Next one, invasive testing. अगर तो डाउन सिंड्रोम की स्क्रीनिंग पॉजिटिव आती है देन वी विल गो फॉर डायग्नोसिस. डायग्नोसिस के लिए वी विल डू इन्वेजिव फीटल टेस्टिंग. सो फर्स्ट वन इज, you can see clearly in this image, we are taking sample from chorionic villi. So time up till 10 to 13 weeks. 10 to 13 weeks and sample is trophoblast. इसके हम sample के लेंगे trophoblast. So this is called as chorionic villi sample. So overall fetal loss is 1%. Means यहाँ पे abortion होने के chances हो सकते हैं up to 1%. So second one diagnostic test is amniocentesis. Amniocentesis timing up till 15 to 20 weeks. Up till 15 to 20 weeks. Sample amniocytes and fetal dermal fibroblast. So this one is the amniocentesis. यहाँ पे हम क्या करेंगे? Ultrasound guided. We will take the sample of amniotic fluid, and the fetal loss is 0.5%. Means chances of abortion is 0.5%. This one is the second test, and the third one is chordocentesis. Chordocentesis, we will take the samples from fetal blood sample after 18 weeks. And the fetal loss is maximum up to 1.5 to 3%. 1.5 to 3%. So these are the diagnostic tests for Down syndrome. First one is the amniocentesis, second one is a chorionic villi sampling, and the third one is chordocentesis. So next important topic is fetal surveillance. Just we have to check the fetal heart rate. कि fetal heart rate कैसा है. So इसमें two components है, NST and CTG. So NST is non-stress test done for antepartum fetal heart rate monitoring. CTG means cardiotocography, done for intrapartum fetal heart rate monitoring during labor. So दोनों में difference क्या है? NST में patient is not in labor. और जब भी हम CTG करेंगे पेशेंट होगा लेबर. patient in labor. So this is the difference between NST and CTG. So let's talk about NST, non-stress test. अभी होता क्या है? So non-stress test done after 32 weeks of gestation. 32 weeks of gestation. So what are the components? What are the components? So NST में 3 components होंगे. First one is fetal heart rate. Second one is beat to beat variability. And the third one is the fetal acceleration. So normal fetal heart rate is 110 to 160 beats per minute. Fetal heart rate, normal fetal heart rate is 110 to 160 beats per minute. Second component is beat to beat variability. Means fetal heart rate is not constant. कभी भी constant नहीं रहता है. So not constant. हमेशा क्या रहेगा? In a zigzag form. In a zigzag form. Normal beat to beat variability is 5 to 25 beats per minute. So it donates normal fetus, means healthy fetus. अगर तो वेरिएबिलिटी है 5 to 25 beats per minute, it means fetus is healthy. यहाँ पे कोई प्रॉब्लम नहीं है fetus में. Second one, if the absent variability, अगर आपको फाइंडिंग्स मिल रही है absent variability and less than 5, it means fetal distress. It means fetal distress. And the third component is fetal acceleration. So while fetal movement, जैसे ही fetus move करेगा, fetal heart rate suddenly क्या होगी? up जाएगी up to 15 beats per minute for 15 seconds. 15 beats per minute for 15 seconds, which indicates healthy fetus. So ये हुई components of NST. First one is fetal heart rate, second one is beat to beat variability, and the third one is fetal acceleration. So reactive NST means, what is the meaning of reactive NST? At least more than 2 acceleration, each acceleration in 20 minutes with the duration of 15 seconds by at least 15 beats per minute. This is called as reactive NST. Reactive NST means more than 2 accelerations, each in 20 minutes, duration 15 seconds by at least 15 beats per minute. So this one is a reactive NST. Non-reactive, अगर हमारे पास findings आती है non-reactive NST, then we will go for biophysical scoring. Biophysical scoring. Ultrasound guided over 30 minutes. We will check the first component is the fetal tone. Fetal tone. Second one, fetal breathing movements. Gross fetal body movements. Single deep pocket amniotic fluid and non-stress test. So these are the components of biophysical score. Score कितना आना चाहिए? About 2, 2, 2 and 2. So these are the components of biophysical score. If the score हमारे पास आता है 8 or 10 out of 10, it means fetus is healthy. If 6 out of 10, then we will reassess for 24 hours. 24 hours के बाद हम क्या करेंगे? हम इसको फिर से रिपीट करेंगे. If the values is 6, means fetal hypoxia. fetal hypoxia, यहाँ पे हम करेंगे cesarean section. Cesarean section. And what is modified BBP? Modified means amniotic fluid index plus NST. So this is called as modified BPP. So next one is CTG, cardiotocography. So cardiotocography में हम क्या देखेंगे? Decelerations, sudden fall in fetal heart rate by 15 beats per minute for 15 seconds. 15 beats per minute for 15 seconds during uterine contractions. Means जैसे मैंने आपको बताया CTG में क्या होगा, जैसे ही uterine contraction आएगी वैसे ही क्या होगा, fetal heart rate fall करेगा. That is called as deceleration. So what are the types of deceleration? 3 types of deceleration. इस पे हमेशा क्वेश्चन आता है एग्जाम में. First one is early deceleration. Early deceleration means fetal heart rate drops with onset of uterine contraction. Means जैसे ही uterine contraction start होगा, fetal heart rate क्या करेगा, fall करना start कर जाएगा. And जैसे ही contraction over होगा, fetal heart क्या होगा, normal हो जाएगा. So cause. So what is the cause? Cause of early deceleration. Yes, anyone? Cause of early deceleration? No answer. So cause of early deceleration is head compression. Head compression. Head compression. Yes. So wait and watch. Wait and watch. Head compression. तो ये हुआ early deceleration. Second one is late deceleration. Late means fetal heart rate starts falling after the peak of uterine contractions. Means जैसे ही uterine contractions peak पे जाएंगी वैसे ही fetal heart क्या होगा, fall होना start हो जाएगा. So in this image you can see upper part is 2 graphs. Upper one is fetal heart rate and the lower one is uterine contractions. So जैसे ही uterine contraction peak पे जाएगी fetal heart rate क्या करेगा, fall करेगा. So what is the cause of late deceleration? Cause is uteroplacental insufficiency. Insufficiency means indication for cesarean section. Means fetal hypoxia, indication for cesarean section. So last one is variable deceleration. Variable deceleration, there is a no regular pattern between fetal heart rate and uterine contraction. Means fetal heart rate कहीं भी fall करेगा and uterine contractions. Okay, so this one is seen in, what is the cause of variable deceleration is cord compression. Cord compression. Cord compression. So, okay, tell me the conditions जिनमें में cord compression दिखेगा. Umbilical cord compression. Yes, anyone? Cord compression is seen in oligohydramnios and in case of post-term pregnancy. Post-term pregnancy. So clear to all of you? First one is early deceleration, causes head compression. Second one, late deceleration, causes uteroplacental insufficiency. And the third one is variable deceleration, which is seen in cord compression. So this is all about CTG. So next important topic, that is antepartum hemorrhage. Antepartum hemorrhage. So in case of antepartum hemorrhage, we will discuss about placenta previa and abruptio placenta. So placenta previa means if placenta is implanted over the lower segment of the uterus completely and partially. So depending upon the degree of extension, there are 4 types of placenta previa. So first one, type 1 is low lying placenta. This one is a type 1. type 1. So in this image, you can see placenta is 2 centimeter. Within 2 centimeters, internal oats. Internal oats के within 2 centimeters रहेगा. That is called as low lying placenta. And the type 2. Type 2 placenta is called as marginal placenta. Yes, marginal placenta. यहाँ पे क्या होगा? Margins touch करेंगे internal os को. This is called as marginal placenta. And the third one is partial placenta previa. इसमें क्या होगा? Partially cover करेगा internal os को. Partially covering the internal os. And the last one is complete placenta previa. Complete placenta previa. मीन्स जो प्लेसेंटा होगा पूरी तरह से इंटरनल ऑर्स को कवर कर देगा. सो देर आर 3 टाइप्स ऑफ प्लेसेंटा प्रीविया. टाइप 1, टाइप 2, टाइप 3 एंड टाइप 4. एंड टाइप 4. सो नेक्स्ट वन, abruptio placenta. Abruptio placenta means placenta is implanted normally. Normally implant होगा but it separates prematurely. Prematurely क्या होगा? Separate हो जाएगा. That is called as abruptio placenta. So in case of abruptio placenta, there are 3 types: revealed, concealed, and mixed. So in first image, you can see there is a bleeding after separation and blood gets space to come out. That is called as revealed placenta previa. That is called as revealed placenta abruptio. And the second one, इसमें क्या होगा? Bleeding हुई but blood doesn't get space to come out. That is called as concealed placenta previa. Concealed placenta previa. And the third type is mixed. Third one is mixed. So revealed, concealed, and mixed. So next important point is how to differentiate between placenta previa and abruptio placenta. So कैसे differentiate करेंगे इन दोनों में? So first of all is bleeding. तो bleeding का pattern कैसा होगा? Placenta previa and abruptio placenta. So in case of placenta previa, bleeding bright red in color. Bright red in color. And in case of abruption, dark colored bleeding. This point is very important. Differentiate between placenta previa and abruptio placenta. So in case of placenta previa, bright red bleeding, painless, causeless, and causeless and recurrent. But in case of abruptio placenta, bleeding associated with pain. Bleeding associated with pain, and the cause, it could be a pregnancy-induced hypertension and trauma. Okay, so in case of placenta previa, bright red in color bleeding, which is causeless and painless. In case of abruptio, associated with pain, cause क्या हो सकता है? Pregnancy-induced hypertension and trauma. So next one, on per abdomen examination. जैसे ही आप यूट्रस को एग्जामिन करोगे, then you will see in case of placenta previa, soft and relaxed uterus. Soft and relaxed uterus. In case of abruptio, you will see hard, tender, and tensed uterus. Tensed uterus. So fundal height, जैसे हम fundal height measure करेंगे, in case of placenta previa, equal to period of gestation. But in case of abruptio placenta, more than period of gestation in case of concealed placenta previa. So these are the abdominal findings. Fetal heart rate. Please remember कि fetal heart rate हमेशा हमें placenta previa में audible रहेगा. But in case of abruptio placenta, due to bleeding, इतनी bleeding हो जाएगी हमें fetal heart rate हम अच्छे से audible मतलब सुन ही नहीं पाएंगे. So in case of placenta previa, fetal heart rate audible. Abruptio में because of fetal distress. Because of fetal distress, not audible. Sometimes not audible. So PV examination. Okay, tell me PV examination in case of placenta previa. PV examination in case of placenta previa is contraindicated. Is contraindicated. जैसे हम पीवी करेंगे बहुत ज्यादा ब्लीडिंग शुरू हो जाएगी बिकॉज प्लेसेंटा इज हाईली वैस्कुलर सो कॉन्ट्राइंडिकेटेड इन केस ऑफ प्लेसेंटा प्रीविया बट यस इन केस ऑफ अब्रप्शियो वी कैन डू पीवी बट फर्स्ट रूल आउट प्लेसेंटा प्रीविया बाय अल्ट्रासाउंड अब्रप्शियो में तो प्लस हमें पीवी करना ही है क्यों करना है बिकॉज जैसे ही अब्रप्शियो का पेशेंट आएगा आपके पास विद कंप्लेंट ऑफ ब्लीडिंग जैसे ही प्लेसेंटा का सेपरेशन होगा देन रिलीज क्या होगा थ्रोम्बोप्लास्टिन एंड दिस थ्रोम्बोप्लास्टिन इज यूट्रोटोनिक एजेंट मीन जैसे प्लेसेंटा सेपरेशन हुआ थ्रोम्बोप्लास्टिन रिलीज हुआ इससे क्या होगा यूट्राइन कॉन्ट्रैक्शंस बढ़ जाएंगी तो जब भी पेशेंट हमारे पास आएगा अब्रप्शियो प्लेसेंटा का पेशेंट आएगा विथ लेबर जब भी आएगा लेबर में आएगा सो वी हैव टू चेक द डायलेटेशन ऑफ द सर्विक्स इसलिए फर्स्ट रूल आउट प्लेसेंटा प्रीविया बाय अल्ट्रासाउंड देन वी कैन डू पीवी एग्जामिनेशन इन केस ऑफ अब्रप्शियो प्लेसेंटा नेक्स्ट वन इज द इन्वेस्टिगेशन इन केस ऑफ प्लेसेंटा प्रीविया टीवीएस ट्रांसवेजाइनल सोनोग्राफी बट इन केस ऑफ अब्रप्शियो clinically diagnosed. So ये हुआ difference between abruptio placenta and placenta previa. So next one is management. In case of placenta previa. So active management and conservative या फिर expectant management. So if the vitals are stable, fetal heart rate is normal, bleeding, no bleeding, ultrasound normal and period of gestation is less than 37 weeks. Then according to McCaffey-Johnson's protocol, take the pregnancy till 37 weeks, then do cesarean section. But in case of active management, if the vitals are not stable, fetal heart rate हमें मिल रहा है यहाँ पे distress, active bleeding and ultrasound में क्रॉस या फिर किसी तरह का भी congenital abnormality then immediate cesarean section. So next one, ये तो हुआ ट्रीटमेंट ऑफ प्लेसेंटा प्रीविया. सो इन केस ऑफ अब्रप्शियो इसमें भी कंजर्वेटिव मैनेजमेंट एंड एक्टिव मैनेजमेंट. इफ द पेशेंट इज इन लेबर, जैसे मैंने आपको बताया है जब भी अब्रप्शियो में पेशेंट आएगा हमेशा आएगा इन लेबर. सो इफ द पेशेंट इज इन लेबर, most of the cases में no major separation, fetal heart sound is good, then artificial rupture of membrane plus injection oxytocin, then vaginal delivery, conservative management. But in case of active management, if the patient is not in labor, cervix is not favorable, major separation and fetal distress, then immediate cesarean section. So this is a treatment of abruptio placenta. And the most common complication of abruptio placenta is DIC. Okay, DIC. So this is all about antepartum hemorrhage. So next one is pregnancy-induced hypertension. So two types of pregnancy-induced hypertension. First one is gestational hypertension and the second one is preeclampsia. In both conditions, दोनों ही conditions में BP बढ़ना शुरू होगा after 20 weeks. Get normal within 12 weeks of delivery. Means 12 weeks after delivery क्या होगा, BP normal आ जाएगा. Then what is the difference between gestational hypertension and preeclampsia? Yes, anyone? What is the difference between gestational hypertension and preeclampsia? So in case of gestational hypertension, proteinuria and the signs of end organ damage will be absent. But in case of preeclampsia, proteinuria, signs of end organ damage will be present. So this is the difference between gestational hypertension and preeclampsia. So what is the meaning of proteinuria? Proteinuria means 24 hours urinary protein more than 300 milligrams. More than 3 placenta previa plus it is, yes. If the placenta, in case of preeclampsia, अगर patient को convulsions आने start हो जाए, that is called as eclampsia. So proteinuria means 24-hour urine proteins more than 300 milligrams, protein and creatinine ratio more than 0.3, and the dipstick method में हमारे पास आ रहा है 1+ proteins. That is called as proteinuria. Next one, end organ damage means if the serum creatinine levels are more than 1.1, platelet counts less than 1 lakh, liver enzymes raised, fetal edema present, and cerebral and visual symptoms are present. That is called as end organ damage. So next point is signs of impending eclampsia. Means आपके पास patient आया है pre-eclampsia का. But what are the signs कि जिसे हम देख के कह सकते हैं कि patient को seizures आने वाले हैं. So 3 important signs that are, first one, epigastric pain due to stretching of liver capsule. Second one, severe headache. Patient will complain of severe headache and dizziness. due to cerebral edema. And the third important sign is visual disturbance. Patient will complain of blurring of vision and scotoma. And this is because of occipital lobe edema. So these are the three main signs of impending eclampsia. First one is epigastric pain. Second one is severe headache and dizziness. And the third one is visual disturbance या फिर blurring of vision, blindness या फिर scotoma. So next one-liner questions. Most common cause of sudden death in a woman with eclampsia. So most common cause of sudden death in a woman with eclampsia. Anyone? Most common cause? So most common cause of sudden death is intracranial hemorrhage. Intracranial hemorrhage. So most common organ and first organ involved कौन सा होगा? Kidney. And the first hematological manifestation in pregnancy induced hypertension is thrombocytopenia. Thrombocytopenia. And the complication of severe preeclampsia. So what is the complication of severe preeclampsia? Complication. Yes, anyone? Complication of severe preeclampsia. HELP syndrome. Sheehan, no. HELP syndrome. HELP syndrome. H means hemolysis, EL means elevated liver enzymes, and LP means low platelet count. So HELP syndrome. So management in case of pregnancy induced hypertension. So अगर तुम्हारे पास patient आ रहा है with hypertension, only hypertension, raised BP, then drug of choice will be labetalol. Drug of choice will be labetalol. You can give methyl dopa, hydralazine and nifedipine. But अगर पूछा जाता है drug of choice, that is labetalol. Definitive management of PIH. Definitive management is termination of pregnancy. Termination of pregnancy. So, इस पे कई बार क्वेश्चन आता है termination of pregnancy in case of severe preeclampsia, in case of eclampsia and mild preeclampsia. So, अगर तो patient को है mild preeclampsia, then termination of pregnancy at 37 weeks. 37 weeks. Severe preeclampsia में 34 weeks of gestation. 34 weeks of gestation. But in case of eclampsia, impending eclampsia and HELP syndrome, immediate termination of pregnancy irrespective of period of gestation. Irrespective of period of gestation means यहाँ पे हमें pregnancy को termination करना है. क्यों करना है? Because first हमें किसको बचाना है? मदर को. Okay, so अगर हम मदर को ही नहीं बचा पाएंगे तो हम fetus को भी नहीं बचा पाएंगे. So termination of pregnancy irrespective of period of gestation. So next one is drugs. ड्रग्स कॉन्ट्राइंडिकेटेड इन प्रेगनेंसी. कौन सी ड्रग्स हैं जो हम प्रेगनेंसी में नहीं दे सकते हैं? फर्स्ट वन इज एटेनोलॉल. सेकेंड वन ACE inhibitors, that is enalapril, and the last one is angiotensin receptor blockers, losartan. Losartan. So these are the drugs which are contraindicated in pregnancy. So next point is eclampsia management. अगर आपके पास पेशेंट आता है with eclampsia, सीजर्स हैं पेशेंट को, then आपका फर्स्ट स्टेप क्या होगा? The first step will be secure airway. Okay, then anticonvulsant. एंटीकन्वर्जन कौन सा यूज करेंगे? मैग्नीशियम सल्फेट. मैग्नीशियम सल्फेट. Then anti-hypertensive drug. Most commonly used, Preterm. Then termination of pregnancy, irrespective of period of gestation. Period of gestation. So next important one is dose of magnesium sulfate. So इसमें हम डोज देंगे according to pre-chart regimen. Dose will be 14 grams. Means 4 grams IV slow and 10 gram of dose divided into 2. 5 grams plus 5 grams. Intramuscular. Intramuscular. Okay. And what is the normal magnesium sulfate value? Normal value कितना रहेगा? 4 to 7 milliequivalent per liter. So this is a normal value of magnesium sulfate. So जैसे हम magnesium sulfate देंगे, साथ ही साथ हम चेक करेंगे साइंस ऑफ मैग्नीशियम टॉक्सिसिटी कि पेशेंट को मैग्नीशियम टॉक्सिसिटी तो नहीं हो रही. सो फर्स्ट जो हम चेक करेंगे दैट इज लॉस ऑफ नी जर्म्स. इफ द वैल्यू ऑफ मैग्नीशियम सल्फेट इज मोर देन 10 milliequivalent per liter. First one is knee jerk. Second one, respiratory paralysis at 15 milliequivalent, and the last one is cardiac arrest. Cardiac arrest if the value of magnesium sulfate more than 24 milliequivalent per liter. So these are the signs of magnesium toxicity. So antidote क्या रहेगा? Injection calcium gluconate. Injection calcium gluconate. So next topic is GDM, gestational diabetes mellitus. So in case of GDM, yes, doctor, catheterization for urine output फॉर मॉनिटरिंग ये बहुत जरूरी है. ऐसा नहीं है कि हम पेशेंट को मैग्नीशियम सल्फेट देते जा रहे हैं और यूरिन आउटपुट चेक ही नहीं कर रहे हैं. सो यूरिन आउटपुट मेजरमेंट इज वेरी वेरी इंपॉर्टेंट जब भी आप पेशेंट को मैग्नीशियम सल्फेट से ट्रीट कर रहे हैं. सो नेक्स्ट वन इज GDM, जेस्टेशनल डायबिटीज मेलाइटिस. सो इसमें इंपॉर्टेंट पॉइंट क्या है? स्क्रीनिंग. सो स्क्रीनिंग शुड बी डन इन ऑल प्रेग्नेंट फीमेल्स. Screening should be done in all pregnant females. Time at first antenatal visit. Antenatal visit. Why? क्यों करेंगे हम स्क्रीनिंग? What is the cause? क्यों करते हैं हम स्क्रीनिंग GDM की? Because first trimester is period of organogenesis. फर्स्ट ट्राइमेस्टर में क्या होगा? जो फीटस के ऑर्गन्स हैं वो बनने स्टार्ट हो जाएंगे. फर्स्ट ट्राइमेस्टर में ऑर्गन्स फॉर्मेशन हो जाएगा. सो अगर फर्स्ट ट्राइमेस्टर में शुगर्स हाई रही, देन formation of free radicals. Formation of free radicals. और ये free radicals क्या करेंगे? They will cross the placenta. They will cross the placenta and lead to fetal anomalies. Fetal anomalies. So that's why screening is important in first trimester. First trimester. So in first antenatal visit, अगर आपके पास sugars levels आ रहे हैं normal, then repeat at 24 to 28 weeks to check GDM. So what anomalies do we see? Anomalies में cardiac anomaly हो सकती है डॉक्टर साहब, sacral agenesis हो सकती है, neural tube defects हो सकते हैं in first trimester अगर sugars high हैं. Okay, so if the first antenatal blood sugars are normal, then repeat at 24 to 28 weeks. Because अगर patient को GDM होगा, वो कब होगा? 24 to 28 weeks. Okay. So what are the screening tests? First step, one-step technique according to Government of India by DIPSI guidelines. By DIPSI guidelines, according to Government of India, irrespective of previous meal, means यहाँ पे हमें fasting नहीं रखना है patient को, give 75 grams of oral glucose. Oral glucose. Okay, then after 2 hours, sugar values are estimated. Sugar values are estimated. So if the values are more than and equal to 140, तो यहाँ पे हमारा diagnosis हो गया GDM. And if the values are more than and equal to 200, तो यहाँ पे diagnose हुआ overt diabetes. So what is the meaning of overt diabetes? Means patient पहले से ही diabetic है, conceive करने से पहले से ही diabetic है, जिसको हम कहते हैं overt diabetes. So GDM, if the values are more than and equal to 140, overt diabetes if the values are more than equal to 200. Okay. So next one is one step screening by WHO. जो मैंने अभी आपको बताया, that is by Government of India, and the next one is by WHO. So WHO ने क्या कहा है यहाँ पे? We can do any time during pregnancy. During pregnancy we can do any time. Done fasting. यहाँ पे हमें करना है fasting 75 grams of oral glucose. Then check क्या करेंगे? First one is fasting blood sugar. If the values are more than 92, after 1 hour, if the values are more than 180, and after 2 hours, if the values are more than 153, then diagnosis of GDM according to WHO. Diagnosis of GDM. But in case of overt diabetes, fasting more than 120, 2 hours more than 200, then the diagnosis of overt diabetes. Overt diabetes. So clear to all of you? By Government of India अलग values हैं, according to WHO अलग values. So what are the gross congenital anomalies are seen? कौन सी anomalies हैं और कब मिलेंगी, कौन सी कंडीशन में ज्यादा होंगी? So gross congenital anomalies seen in GDM और overt diabetes. कौन सी कंडीशन में मिलेंगी, GDM और overt diabetes? Yes, anyone? So seen in overt diabetes. Yes, I am getting right answers here. Overt diabetes. Yes. Okay, tell me most specific cardiac anomaly. Most specific cardiac anomaly. Yes, Dr. Bhuwana. GDM occur after embryonic period. Yes, GDM mostly कब होगा 24 to 28 weeks पे. Because at the time of 24 to 28 weeks जितने भी hormones होंगे like human placental lactogen, cortisol, prolactin, estrogen, progesterone ये सब क्या होंगे मैक्सिमम होंगे at the time of 24 weeks. इसलिए जो GDM होगा वो होगा after 24 weeks. Okay. So okay, tell me more specific cardiac anomaly. Yes, Dr. Vicky, transposition of great vessels. TGA, transposition of great arteries. And the most specific anomaly. Most specific anomaly. Sacral agenesis. Sacral agenesis. And the most common cardiac defect. Most common cardiac defect. Ventricular septal defect. तो स्पेसिफिक कौन सा होगा टीजीए एंड द मोस्ट स्पेसिफिक मींस जो हमें सिर्फ ओवर्ट डायबिटिक में ही मिलेगा दैट इज सैक्रल एजेनेसिस. सो नेक्स्ट है मैनेजमेंट इन केस ऑफ जीडीएम. सो इन केस ऑफ जीडीएम फर्स्ट स्टेप क्या होगा डाइट मॉडिफिकेशन एंड एक्सरसाइज. पेशेंट को एडवाइस करेंगे कि थोड़ा सा डाइट मॉडिफिकेशन कीजिए एंड एक्सरसाइज. देन मॉनिटर sugar levels. Then after 2 weeks, if 2 hours sugars are less than 120, then continue same treatment. Continue same. Okay. But if the values are more than 120, then start insulin. Start insulin. यहाँ पे हम इंसुलिन स्टार्ट कर देंगे पेशेंट. सो इन केस ऑफ ओवर्ट डायबिटिक no role of diet modification and oral hypoglycemic agents. यहाँ पे हम ना ही डाइट मॉडिफिकेशन करेंगे और ना ही हम यहाँ पे किसी तरह की ओरल मेडिकेशन देंगे. स्टार्ट इंसुलिन डायरेक्टली with the dose of 0.7 to 1 international unit per kg. Oral drugs are contraindicated. Oral drugs are contraindicated. Except metformin. Except metformin and glyburide. Glyburide. So दोनों टैबलेट्स हम दे सकते हैं. अदरवाइज जितने भी ओरल ड्रग्स हैं ये क्या है कॉन्ट्रा इंडिकेटेड. So this is all about GDM and overt diabetes. So next topic is ectopic pregnancy. Ectopic pregnancy. So most common site of ectopic pregnancy, ampulla. Ampulla of fallopian tube. So ampulla, then isthmus, then infundibulum, and the last one is interstitium. Last one is interstitium. So जैसे आपको पता ही है ampulla is the widest part of the fallopian tube, most common site of fertilization and most common site of ectopic pregnancy. So most common site for fertilization and most common site for ectopic pregnancy. So next, outcome of ectopic pregnancy. So what is the outcome of ectopic? अगर किसी फीमेल को ectopic pregnancy है तो इसका outcome क्या रहेगा? Yes, anyone? Outcome of ectopic pregnancy. Yes, Dr. Bhuwana, rupture and अगर किसी फीमेल को एक्टोपिक प्रेगनेंसी है तो इसके आउटकम दो रहेंगे. फर्स्ट वन इज रप्चर, यस, एंड सेकंड वन डॉक्टर विकी, आपका आंसर सही है, शॉक. बट शॉक कब होगा? आफ्टर रप्चर ऑफ एक्टोपिक प्रेगनेंसी. यस, पेशेंट शॉक में चला जाएगा. सो आउटकम ऑफ एक्टोपिक, फर्स्ट वन इज रप्चर, या तो ट्यूब रप्चर हो जाएगी, यस डॉक्टर बुवाना, या फिर क्या होगा? अबॉर्शन. अबॉर्शन, या तो रप्चर हो जाएगी या फिर क्या होगा? अबॉर्शन हो जाएगा एक्टोपिक प्रेगनेंसी का. सो मोस्ट कॉमन साइट फॉर रप्चर इज, most common site for rupture is isthmus, and the most common site for abortion is ampulla, ampulla of the fallopian tube. So time of rupture, तो इस पे कई बार क्वेश्चन आता है. टाइम ऑफ रप्चर, isthmus at 6 weeks, ampulla 8 weeks, and इंटरस्टिशियल एंड कॉर्नुआ. अगर कॉर्नुआ ऑफ द यूट्रस पे प्रेगनेंसी होती है, टॉपिक प्रेगनेंसी, देन ये सर्वाइव करती है अप टू 10 to 12 वीक्स. सो दिस इज द मोस्ट डेंजरस साइट, मोस्ट डेंजरस साइट. यस यस डॉक्टर विकी, 12 वीक्स इंटरस्टिशियल. अगर यहाँ पे टॉपिक प्रेगनेंसी रप्चर होगी तो मैसिव ब्लीडिंग हो जाएगी, मैसिव ब्लीडिंग हो जाएगी. So what is the site for longest duration of ectopic pregnancy? Yes, anyone? Longest duration of ectopic pregnancy. कौन सी साइट पे रहेगी? Yes, anyone? Longest duration of ectopic pregnancy. Abdominal ectopic. Abdominal ectopic. Longest duration. Abdominal ectopic. So investigation of choice, ultrasound. अगर आपके पास पेशेंट आता है with complaint of bleeding PV with history of amenorrhea 6 to 10 weeks. Okay. So first step क्या रहेगा हमारा? UPT. So UPT हमारे पास आएगा पॉजिटिव. UPT will be positive. So investigation of choices, transvaginal sonography. So first sign क्या होगा? empty uterus. Empty uterus. Yes, doctor. Yes, ring of fire sign. Yes. And the second sign, gestational sac with cardiac activity present or maybe absent in fallopian tube. In fallopian tube means हमारे पास यूट्रस आया एम्प्टी, हमें कोई यहाँ पे प्रेगनेंसी नहीं मिल रही. बट सेकेंड साइन इज जेस्टेशनल सैक विद कार्डियक एक्टिविटी may be present or not in fallopian tubes. That is called as Bagel sign. It is called as Bagel sign. Ring of fire sign. Yes, ring of fire sign. So what is the management? इस पे कई बार क्वेश्चंस आते हैं. मैनेजमेंट ऑफ एक्टोपिक प्रेगनेंसी. सो फर्स्ट स्टेप इज रिसस्टिटेशन. पेशेंट आपके पास आया एक्टोपिक प्रेगनेंसी का, जैसे पेशेंट आएगा फर्स्ट स्टेप क्या होगा? रिसस्टिटेशन. एंड इन केस ऑफ रप्चर्ड, सी रप्चर्ड एक्टोपिक में अलग से ट्रीटमेंट होगा और इन केस ऑफ अनरप्चर्ड में अलग से ट्रीटमेंट होगा. सो इन केस ऑफ रप्चर्ड मीन्स रप्चर हो गया प्रेगनेंसी, बेस्ट मैनेजमेंट इज सर्जरी. यहाँ पे हम करेंगे सर्जरी. सर्जरी कौन सी करेंगे? यूनिलैटरल salpingectomy. Unilateral salpingectomy. Yes, Dr. Vicky and Dr. X Blast X कैसे नाम है? Salpingectomy. Okay. If the vitals are stable, then go for laparoscopy. Laparoscopy. If the vitals are not stable, then laparoscopy. So this is the management of ruptured ectopic pregnancy. So in case of unruptured ectopic pregnancy, conservative management and surgical management. So conservative management में if the patient is stable, compliant and motivated, patient को हमने समझा दिया है, ओके, जो जो कॉम्प्लिकेशंस आएंगे सब समझा दिए हैं मेडिकल ट्रीटमेंट में. So we will check the beta HCG levels. If the beta HCG levels are less than 5,000 international unit, yes, and the SAT sign is less than 4 centimeter, and the cardiac activity is absent, then the drug of choice will be, yes, Dr. Ayush, methotrexate. Drug of choice is methotrexate. Methotrexate with the dose of 50 milligram per m². Okay, methotrexate. So next one is surgical management. If the family is completed, then agar family completed, then we can remove the fallopian tube. Then unilateral salpingectomy. Unilateral salpingectomy. If the family is not complete, then treatment क्या होगा? Linear salpingostomy. Linear salpingostomy. So methotrexate करता क्या है? जो भी fetal formation होगा उसको डिस्ट्रॉय कर देगा. ओके, जिससे क्या होगा? सी पहले ये प्रेगनेंसी वायबल नहीं रहेगी. ओके, और जैसे ही जो एम्ब्रियो फॉर्मेशन हुआ है इसको डिस्ट्रॉय कर देगा methotrexate. So family is not complete, then linear salpingostomy. Salpingostomy means यहाँ पे हम ट्यूब को नहीं निकालेंगे, just we will give the incision. Incision देंगे यहाँ पे. Suppose ये है ectopic pregnancy, ओके, और हाइड्रोडाइसेक्शन से हम ectopic pregnancy को निकाल देंगे और जो incision दिया है इसको ओपन छोड़ देंगे. That is called as linear salpingostomy. So next topic is gestational trophoblastic disease, means molar pregnancy. Molar pregnancy. Molar pregnancy. So molar pregnancy is of two types, partial mole and complete mole. So partial mole, what is the difference between partial mole and complete mole? Partial mole में one ova and two sperms. Fertilization between one ova and two sperms. So this is dispermic. Dispermic means fertilization of one ova with two sperms, and this is called as triploidy 69XXY. Most commonly 69XXY. So in case of complete mole, empty ova and fertilization of one sperm. Fertilization of one sperm. So monospermic. So this one is the monospermic. Yes, and diploid 46. इसमें होगा क्या? क्रोमोसोम नंबर्स हो जाएंगे डुप्लीकेट. सो 46XX 46XX. So this pregnancy is not viable. Molar pregnancy is not viable pregnancy. So investigation of choice. Investigation of choice will be ultrasound. Ultrasound, and the gold standard is histopathological examination. So investigational choice is ultrasound and the gold standard is histopathological examination. So most important point is ultrasound images of complete mole and partial mole. Complete mole and partial mole. Okay. So in complete mole, this is an ultrasound image of snowstorm appearance. So complete mole में आपको क्या मिलेगा? Snowstorm appearance. And in case of partial mole, yes, anyone in case of partial mole? Cystic placenta. Cystic placenta means placenta में आप देखेंगे small cyst and misdiagnosed as missed abortion and misdiagnosed as missed abortion. Fetal parts may be present or not. Normally क्या होगा? In case of complete mole, fetal parts will be absent. But in case of partial mole, fetal parts will be present. और अल्ट्रासाउंड में डिपेंड करता है कि आपको fetal parts visible हैं या फिर नहीं. So difference between complete and partial mole. Okay. So what is the management? Management of molar pregnancy. Anyone? Guess what is the management of molar pregnancy? Suction and evacuation. Suction and evacuation. Yes, Dr. Vicky, P57 KIP2. Immunostaining will be absent in complete mole. क्योंकि complete mole में क्या होगा? Only जो sperms हैं और जो भी genetic material होगा वो होगा paternal. But in case of partial mole, maternal and paternal दोनों ही genetic material होंगे present. Suction and evacuation. Check curettage. And then histopathological examination. Yes, Dr. Ayush, curettage करेंगे and histopathological examination. So in case of theca lutein cyst, okay, tell me, in case of molar pregnancy, इसमें theca lutein cyst क्यों होंगे? What is the cause of theca lutein cyst in case of molar pregnancy? Theca lutein cyst. कौन सा हार्मोन है जो हाई रहेगा इन केस ऑफ मोलर प्रेगनेंसी? यस, बीटा एचसीजी लेवल्स. जितना मोलर प्रेगनेंसी में होता क्या है? एक्सेसिव प्रोलिफरेशन ऑफ ट्रोफोब्लास्ट. जितने ज्यादा ट्रोफोब्लास्ट होंगे उतना ही ज्यादा क्या होगा? फॉर्मेशन ऑफ बीटा एचसीजी लेवल्स. सो बीटा यूनिट is for measurement of pregnancy and the alpha unit of beta HCG is equal to TSH, FSH and LH. इसीलिए in complete mole, if the beta HCG levels are high, then patient को क्या complications आएंगी? Hyperthyroidism and theca lutein cyst because of raised LH. So in case of theca lutein cyst, no active management. After 2 to 3 months, suction and evacuation के after 2 to 3 months क्या होगा? जो theca lutein cyst होंगे ये क्या हो जाएंगे? अपने आप ही spontaneously dissolve हो जाएंगे. Okay, so why follow up is important? Dr. Saad, your question is how create baby and what is FSH? See, in case of molar pregnancy, यहाँ पे जो यूट्रस होगा इसमें फॉर्मेशन क्या होगा, एक्सेसिव ट्रोफोब्लास्ट, इसमें फॉर्मेशन ऑफ बेबी होगा ही नहीं। इतने ज्यादा ट्रोफोब्लास्ट होंगे कि कंप्लीटली इंटायरली यूट्रस को भर देंगे ट्रोफोब्लास्ट से। और पेशेंट विल कम विद कंप्लेंट ऑफ ब्लीडिंग पर वेजाइनम, ब्लीडिंग पर वेजाइनम। So for why follow-up is important? Because there is a risk of GTN, gestational trophoblastic neoplasia. See, molar pregnancy is a benign disease, but it can be malignant. इसलिए फॉलोअप इज वेरी इंपॉर्टेंट। और फॉलोअप में हम चेक क्या करेंगे, बीटा एससीजी लेवल्स। So most common, these are the one-liner questions. Most common GTN after H mole evacuation, that is invasive mole. And the most common GTN after full-term pregnancy, that is choriocarcinoma. So patient को हम follow-up रखेंगे, beta HCG levels. If the 3 weekly reports are normal, then we will call the patient every month for 6 months. Okay, so in case of partial mole, हमारे पास levels normal आ जाएंगे up till 7 weeks. In case of complete mole, levels will be normal after 9 weeks. So pregnancy will be contraindicated, okay, for 6 months. और in case of contraception, कौन सा contraception देंगे, that is OCPs. So most common site of metastasis of choriocarcinoma is lungs. That is lungs. So what are the findings? Most common appearance, clear pictures of lungs in case of choriocarcinoma metastasis. So most common appearance, yes, Dr. Ayush, Dr. Vicky, most common appearance is cannonball appearance. And the second most common appearance, anyone? Yes, second most common appearance. Second most common appearance, snowstorm appearance. Lung metastasis. Okay, so first image में you can see these are the ball-like structures seen in choriocarcinoma metastasis, lungs में. And the second one, you can see the white out lungs. Yes, snowstorm appearance. All the white shaded lungs. So I think molar pregnancy में इतना important है. Second one is twin pregnancy. आपको ये confirm ही है कि twin pregnancies of 2 types, dizygotic and monozygotic. In dizygotic, there is a fertilization between 2 sperms and 2 ova and formation of 2 zygotes. 2 zygotes are formed and these are non-identical twins. Means इसमें sex same भी हो सकता है fetus का and different भी हो सकता है. In case of monozygotic twins, fertilization between 1 ova and 1 sperm, formation of 1 zygote. यहाँ पे formation होगा 1 zygote and divided into 2 at different periods. Mean जो हमारे पास zygote बना है ये divide कर जाएगा at different period of time. So types of monozygotic twins. अगर तो splitting होती है zygote की day 1 to 3, this is called as dichorionic diamniotic. Diamniotic means 2 amniotic sac and 2 placenta. Chorionic means placenta. 2 placenta and 2 amniotic sacs. अगर तो splitting होती है 4 to 8 days, then this is called as monochorionic diamniotic. Monochorionic means 1 placenta and 2 amniotic sac. If the splitting occurs 8 to 13 days, then monochorionic, monoamniotic. Means one amniotic sac, इसमें 2 fetus and 1 placenta. Okay. And the last one, if the splitting occurs 13 to 15 days, then conjoined twins. Conjoined twins. आपने देखे ट्विंस देखे होंगे, या तो चेस्ट वॉल से दोनों जुड़े होंगे या फिर हेड से जुड़े होंगे. दैट इज कॉल्ड एज conjoined twins. सो गुड प्रोग्नोसिस किसका रहेगा? गुड प्रोग्नोसिस डाइकोरियोनिक, डाइअमनियोटिक. एंड बाकी सबका रहेगा बैड प्रोग्नोसिस बिकॉज ऑफ कॉम्प्लिकेशंस. प्रोग्नोसिस, बैड प्रोग्नोसिस. ओके. So next important ultrasound image. Okay, tell me. First one, lambda sign. Lambda sign. 2 amniotic sacs. So lambda sign is seen in. Yes, anyone? Lambda sign is seen in. And in second image, there is a T sign. Ultrasound T sign. Yes, Dr. Bhuvana. यस डॉक्टर आयुष. यस, सभी का आंसर सही है. सो लैम्डा साइन इज सीन इन, या फिर ट्विन पीक साइन. ट्विन पीक साइन इज सीन इन डाइकोरियोनिक, डाइअमनियोटिक. Dichorionic, diamniotic. And yes, T sign is seen in, T sign is seen in monochorionic, diamniotic. Monochorionic, diamniotic. Okay, clear to all of you? So next one is important, that is time of delivery. Time of delivery. So in case of DC, DA, dichorionic, diamniotic, 38 weeks. Okay. In case of monochorionic, diamniotic, 36 to 37 weeks. But in case of monochorionic, means one placenta and one amniotic sac. So one placenta. This one is the placenta. One amniotic sac. Fetus. One amniotic sac. तो complications किस में रहेंगी? In monochorionic and monoamniotic. So time of delivery 32 to 34 weeks. 34 if present. Yes, 32 to 34 weeks, क्योंकि इसमें complications के chances बहुत ज्यादा रहते हैं. So अगर तो हमें करनी पड़ रही है डिलीवरी एट द टाइम ऑफ 32 वीक्स या फिर विदिन या फिर बिफोर 34 वीक्स या 32 वीक्स, देन गिव स्टेरॉइड्स फॉर लंग मैच्योरिटी. गिव स्टेरॉइड्स फॉर लंग मैच्योरिटी. So this is all about twin pregnancy. Next topic is MTP. So this point topic is very very important, क्योंकि इस पे हमेशा ही क्वेश्चंस आए हैं FMG में. MTP abortions, इस पे हमेशा क्वेश्चंस आते हैं. So MTP is medical termination of pregnancy. Recommendation, please remember the recommendations, new recommendations. So first one, MTP can be done up to 24 weeks. Okay, so fetal anomaly. If the fetal anomalies are present, then 24 weeks and no upper limits. No upper limits. Single doctor opinion. According to 1971 Act, 12 weeks तक important था single doctor opinion, but according to new recommendations, 20 weeks. 20 weeks. And the two doctor opinions, 20 to 24 weeks. 20 to 24 weeks. And more than 24 weeks. अगर किसी fetus में anomalies हैं और आपको MTP करना जरूरी है after 24 weeks, then only after approval of a medical board. आपको मेडिकल बोर्ड से अप्रूवल लेना पड़ेगा. ओके, so these are the recommendations of MD. So next one, medical abortion in first trimester. So first trimester में according to WHO up till 9 weeks, successful rate 95%, and India up to 7 weeks, successful rate 99%. Okay, so what is the method? This one is also important. What is the method of MTP in first trimester? So day one, mifepristone 200 milligram orally. So patient को हम देंगे first tablet day 1 पे mifepristone 200 milligram orally. Then day 3 पे misoprost 800 microgram. Please remember the dose. Mifepristone 200 milligrams and misoprost 800 micrograms vaginal. Best क्या रहेगा vaginally पीछे. So this is the method of first trimester abortion, and you can do suction and evacuation by Kaman cannula, MVA syringe या फिर ovum forceps. Okay, so first one, so these are, so first one is Kaman cannula. So number of the cannula is corresponds to period of gestation. मतलब जितना period of gestation होगा उतना ही number का आपने cannula use करना है connected to the suction machine. Okay, so second one is this one is the ovum forceps. And next one is MVA syringe. Manual vacuum aspiration. Capacity रहेगी 16 ml and pressure 660 mm of H. 660 mm of H. So medical abortion in second trimester. Drugs. Important drugs are misoprost 400 microgram for early vaginal, most commonly used. In second trimester, prostaglandin E1, misoprost 400 microgram vaginally, most commonly हम use करते हैं. Maximum 3 doses. Prostaglandin E2, dinoprost, or you can give prostaglandin F2 alpha, carboprost. So these are the drugs for medical abortion in second trimester. So please remember the dose first trimester में and second trimester में. Yes, Dr. Vijay, I am trying to cover all the topics. तो मैंने जितने भी topics लिए हैं उनका just short notes लिए हैं कि आपको सारा एक बार revise हो जाए. So next important topic is RH incompatibility. So RH incompatibility means if the mother is RH negative and the fetus is RH positive. तो यहाँ पे क्या हो गया है problem. Okay. So if the mother is RH negative and the father is RH negative, दोनों ही negative है, then no problem. But if the mother is RH negative and the father is RH positive, तो यहाँ पे क्या रहेगा problem. Fetus क्या हो सकता है, positive भी हो सकता है and negative भी हो सकता है. Okay, so first pregnancy. Okay, tell me, first pregnancy safe रहेगी या नहीं रहेगी? Anyone? First pregnancy in case of RH negative pregnancy. Yes, I am getting right answers here. Yes, safe. First pregnancy is safe. First time safe for me. Yes, yes, Prenatal. Yes, first pregnancy is safe. See, in case of feto-maternal hemorrhage, if the mother is RH negative and the fetus is RH positive, अगर किसी भी तरह से fetus का blood, even 0.1 ml भी blood अगर mix होता है mother के blood के साथ, most commonly mixing कब होगी? Yes, Dr. Vikas, good evening. So should be given anti-D post delivery. Yes. So after mixing of blood, मदर की बॉडी में क्या फॉर्मेशन होगा? एंटी बॉडीज, एंटी डी एंटी बॉडीज. सो RH एंटीजन अगर मदर की बॉडी में फीटस का ब्लड मिक्स होता है, देन फॉर्मेशन ऑफ RH एंटीजन which stimulates the maternal immune system. Okay, in first pregnancy. So maternal immune system में क्या होगा? Stimulation हो जाएगा. Then which antibodies will be formed? एंटी डी. मदर की बॉडी में फॉर्मेशन होगा एंटी डी एंटीबॉडीज. फर्स्ट एंटीबॉडी IgM. So IgM can't cross the placenta. So after 6 months फॉर्मेशन होगा IgG एंटीबॉडीज का. IgG by the time delivery done. So first pregnancy is safe. कोई प्रॉब्लम नहीं रहेगी फर्स्ट प्रेगनेंसी में. ओके. सो इन सेकेंड प्रेगनेंसी, सो इन केस ऑफ सेकेंड प्रेगनेंसी, मदर इम्यून सिस्टम इज ऑलरेडी प्रिपेयर्ड. मीन्स यहाँ पे मदर का सिस्टम, इम्यून सिस्टम ऑलरेडी बैठा हुआ है अटैक करने के लिए, क्योंकि पहले भी फॉर्मेशन हुई है एंटीबॉडीज की. अभी क्या होगा? क्विकली फॉर्मेशन होगा एंटीबॉडीज का. सो फर्स्ट एंटीबॉडी IgM, क्विकली फॉर्मेशन होगा IgM. ओके. सो दैट इज कॉल्ड एज amnestic effect, amnestic response. सो जैसे ही IgM एंटीबॉडीज फॉर्मेशन होगी, साथ के साथ क्या होगा? फॉर्मेशन ऑफ IgG. और जैसे ही IgG का फॉर्मेशन होगा, these antibodies will cross the placenta. So cross the placenta, then fetal circulation में चले जाएंगे. देन एंटी डी एंटीबॉडी रिएक्शन होगा फीटस की बॉडी में. ओके, कौन सी साइड पे होगा? एनीवन? यस, एंटीजन एंटीबॉडी रिएक्शन. fetal RBCs, fetal RBCs in second pregnancy. एंटी टी एंटीबॉडीज क्या करेंगी? फॉर्मेशन ऑफ एंटीजन एंटीबॉडी रिएक्शन ऑन fetal RBCs, so which lead to hemolysis. hemolysis means यहाँ पे क्या होगा? fetal anemia, fetal anemia. fetal anemia means high drops fetalis, high drops fetalis. So Buddha sign is seen in high drops fetalis. mean जो fetus होगा वो पूरा पानी से भर जाएगा. हेड में भी वाटर, पेरिकार्डियल effusion, pleural effusion, ascites because of severe anemia, because of severe anemia. So second pregnancy complicated, first pregnancy is safe. So what is the management of RH negative pregnancy? So first test हम करेंगे, that is ICT, indirect Coombs test, indirect Coombs test to check the anti-D antibodies in maternal serum, in maternal serum. ये चेक करने के लिए कि मदर की बॉडी में एंटीबॉडीज का फॉर्मेशन हुआ है या नहीं हुआ है. सो फर्स्ट टेस्ट इज ICT, indirect Coombs test. सो आपके पास केस आया है, फर्स्ट केस प्राइमरी ग्रेविडा RH नेगेटिव विद ICT इज नेगेटिव. ICT is negative means, so ICT is negative means mother is not yet sensitized, means mother की बॉडी में अभी तक एंटीबॉडीज नहीं बनी है. सो मीन्स मदर इज नॉट येट sensitized, not yet sensitized. So then we will repeat the ICT levels at 28 weeks. Why 28 weeks? Because mixing of blood कब होगा? Third trimester, most commonly. If the ICT is still negative, then we will give anti-D 300 microgram intramuscular to pregnant female. That is called as antepartum prophylaxis. So that is called as antepartum prophylaxis. Okay. So after delivery, check baby's blood group. If the baby is RH positive, then repeat the injection anti-D 300 microgram intramuscular to mother. This is called as postpartum prophylaxis. Postpartum prophylaxis means at the time of 28 weeks, antepartum prophylaxis. At the time of after delivery, अगर हम इंजेक्शन देंगे, that is called as postpartum prophylaxis. Yes, within 72 hours. Within 72 hours, or you can give this injection till 1 month. So within 72 hours or within 1 month. Okay. So this is the case 1, जिसमें है ICT is negative, means mother is not yet sensitized. In case second case, pregnant female RH negative with ICT is positive. RH negative with ICT is positive. Then we will check the ICT titers. वैसे तो ट्वाइस वीकली होने चाहिए, बट हम स्टार्ट करेंगे 28 वीक्स पे चेक करना. ओके. इफ द टाइटर्स आर लेस देन 1:16, means less antibodies are formed, then we'll repeat the titers weekly. Weekly titers repeat करेंगे and delivery at 37 weeks. 37 weeks. Yes. So if the titers are more than 1:16, means critical antibody titers. It means कि fetal में hemolysis बहुत ज्यादा हो गया है, severe anemia हो गया है fetus में, then we will do weekly Doppler of MCA. MCA means middle cerebral artery Doppler. Middle cerebral artery Doppler, and we will check the PSV, peak systolic velocity. If the value is more than 1.5 mom, mom means multiple of median, then it means यहाँ पे है severe fetal anemia. Then we will do cordocentesis. Fetal की कॉर्ड से हम ब्लड लेंगे, अल्ट्रासाउंड गाइडेड. Yes, and then we will transfuse the blood, intrauterine transfusion up till 34 weeks. Means we have to take the pregnancy till 34 weeks. Okay. यहाँ पे lung maturity होगी, then delivery. And intrauterine transfusion every 2 weeks. हर 2 weeks के बाद हम करेंगे intrauterine transfusion. So this is all about RH negative pregnancy. So next we will discuss about the maternal pelvis. Very important topic. हर बार इसमें से क्वेश्चंस आते हैं. Maternal pelvis. So as we know, 4 types of maternal pelvis. First one is gynecoid pelvis. Gynecoid pelvis, most common pelvis, and classical female pelvis. This one is the classical female pelvis. Okay, so yes, gynecoid is the most common pelvis. Second one, anthropoid pelvis. In case of anthropoid pelvis, anterior posterior, this one is the anterior posterior diameter will be more than the transverse diameter. Okay, so क्वेश्चन में क्या आएगा आपको क्वेश्चन में क्या आएगा? persistent occipito-posterior position या फिर direct occipito-posterior position is seen in. Please remember यहाँ पे आपका आंसर आएगा anthropoid pelvis. Persistent occipito-posterior position and direct occipito-posterior position in case of anthropoid pelvis, and phase to pubic delivery is seen in anthropoid pelvis. Phase to pubic delivery is seen in anthropoid pelvis. So next one, android pelvis. Inlet कैसा रहेगा इसमें? Heart shaped. Heart shaped inlet with prominent ischial spines. Ischial spines will be prominent, and this one is the most common occipito-posterior position during labor. अगर क्वेश्चन में आता है most common occipito-posterior position during labor is seen in, then the answer will be android pelvis. And the deep transverse arrest is seen in android pelvis. Okay. Next one is platyploid pelvis. Platyploid pelvis. So इसमें कैसा रहेगा? Cavity flattened, बिल्कुल flat. Transverse diameter will be more than anterior posterior diameter. So इसमें हमें कौन सा presentation मिलेगा? Face presentation. Yes, face presentation. So these are the types of pelvis. Please don't get confused. Persistent and direct occipito-posterior seen in anthropoid pelvis, and most common cause of occipito-posterior position of the fetal head and deep transverse arrest is seen in android pelvis. So next important, diameters of pelvis. So this one is the inlet. This one is the cavity of the pelvis. Okay, and outlet of the pelvis. Okay, so inlet diameters. So true conjugate. This bone is pubic symphysis, and this one is sacral promontory. So upper border of the pubic symphysis to the sacral promontory. This is called as true conjugate, and diameter कितना रहेगा? 11 centimeter. 11 centimeter. Okay. So sacral promontory to mid of the pubic symphysis. This is called as obstetric conjugate. 10 to 20.5 centimeters. Yes. सभी के आंसर सही चल रहे हैं. And the diagonal conjugate, lower border of the pubic symphysis to sacral promontory. This is a diagonal conjugate. तो इसका कितना diameter रहेगा? Up to 12 centimeters. So these are the inlet diameters of the pelvis. Inlet. 11 centimeters, 10 to 10.5 and 12 centimeters. Next one is cavity. Cavity diameters means midpoint of the pubic symphysis to, this one is the midpoint of the pubic symphysis to sacrum 3 and 4. So ये diameter कितना रहेगा हमारे पास 11 centimeters. 11 centimeters. And the outlet, so this one is the outlet. This part is the outlet. So lower border of the pubic symphysis to tip of the sacrum. Tip of the sacrum, this point, value 11, cavity is 12 centimeter. Cavity is 12 centimeter. Cavity 12 centimeter and outlet 11 centimeter and lower border to tip of the coccyx will be 11 to 13.5 centimeter. So these are the diameters of inlet, mid pelvis and outlet of the pelvis. So clinically we can measure only which type of conjugate, कौन सा measure कर सकते हैं हम by PV, per vaginal examination. Diagonal conjugate. Diagonal conjugate. So जब भी हम PV examination करेंगे, okay, fingers can't touch sacral promontory. See, यहाँ पे fingers touch नहीं करेंगी sacral promontory. If the fingers can touch, then it means diagonal conjugate is less than 12 centimeter. अगर हमारी fingers touch हो रही हैं sacral promontory को during PV, then it means diagonal conjugate is less than 12 centimeter. So if the obstetric conjugate is less than 10 centimeter, जैसे मैंने आपको बताया normal value is 10 to 10.5 centimeter. So if the obstetric conjugate is less than 10 centimeter, then vaginal delivery is not possible, and this is called as contracted pelvis. Contracted pelvis. This is called as contracted pelvis. So normal delivery is not possible in case of contracted pelvis. So next important one is labor. So labor में भी हर बार क्वेश्चंस आते हैं. So यहाँ पे हम just discuss करेंगे abnormal labor. Findings of abnormal labor. So in case of first stage of labor, first stage is divided into latent phase and active phase. So इनमें सबका अलग-अलग है. ACOG के according latent phase is dilatation up to 6 centimeter. WHO के according dilatation up to 5 centimeters and partogram के according dilatation up to 4 centimeters. Active phase more than 6 centimeters. WHO according more than 5 centimeters and partogram more than equal to 4 centimeters. Okay, so first we will discuss about the prolonged latent phase. Prolonged latent phase. In primigravida, if the latent phase is more than equal to 20 hours and multigravida more than equal to 14 hours. And average, yes, Dr. Vicky, average is latent phase is for 12 hours and then priming, and for multi is 8 hours. So what is the cause of prolonged latent phase? See, जो latent phase रहता है वो सबसे lengthy phase रहता है during labor. So what is the cause? या तो cause हो सकता है occipito posterior position या फिर unfavorable cervix. Okay, so management is rest and sedation. मीन्स पेशेंट को हम या तो रेस्ट करवा देंगे या सेडेट कर देंगे. जैसे ही पेशेंट उठेगा या तो वो एक्टिव लेबर में होगा या फिर क्या होगा, हम कॉन्ट्रैक्शंस के लिए ऑक्सीटोसिन स्टार्ट करेंगे. Okay, so next one is active phase. Yes, Dr. Ayushi, enough to clear July. Yes, FMG के लिए this one is enough. I think मैंने जितना भी आपका सिलेबस है उसमें से वो टॉपिक्स लिए हैं जिनमें से मोस्टली क्वेश्चंस आए हैं जो कि मोस्ट इंपॉर्टेंट टॉपिक्स हैं. ओके, सो एक्टिव फेज सर्वाइकल डायलिटेशन इज मोर रैपिड. एक्टिव फेज में क्या होगा, डायलिटेशन जल्दी जल्दी होना स्टार्ट हो जाएगा. ओके, सो इन प्राइमी 1.2 सेंटीमीटर पर आवर, in multi 1.5 centimeter per hour. Okay, or in according to WHO 1 centimeter per hour. एक्टिव फेस में क्या होगा, डायलिटेशन रैपिडली होना स्टार्ट हो जाएगा. ओके, सो व्हाट इज एबनॉर्मल एक्टिव फेस? सो इसमें हमारे पास आएगा प्रोटेक्टेड एक्टिव फेस एंड एक्टिव फेस अरेस्ट. Protected active phase means slow dilatation. Dilatation of cervix is slow, less than 1 centimeter per hour. Less than 1 centimeter per hour. What are the causes of protective active phase? First one is hypotonic contraction. Hypertonic contraction. Hypotonic contractions. Ma'am, I want the live sessions of the या डॉक्टर योशी, अभी तक आपने सब अच्छे से पढ़ लिया होगा आई थिंक. सो दिस इज ए जस्ट ए रिवीजन लेक्चर. सो अभी आपको काफी सब्जेक्ट्स को रिवाइज करना है. सो बेटर है कि जितने भी अभी वीडियोस हैं इस चैनल में आप डेली फॉलो करते रहें वीडियोस को, ताकि आप जो भी आपने अभी तक पढ़ा है वो भी एक बार सारा रिकॉल हो जाए आप. सो कॉजेज ऑफ प्रोटेक्टेड एक्टिव फेज. हाइपोटोनिक कॉन्ट्रैक्शंस मींस कॉन्ट्रैक्शंस तो हैं लेकिन कॉन्ट्रैक्शंस आर हाइपोटोनिक. हाइपोटोनिक मींस कॉन्ट्रैक्शंस यहाँ पे हो रही हैं कम. ओके, सो कॉज देन इन केस ऑफ हाइपोटोनिक कॉन्ट्रैक्शंस give injection oxytocin and artificial rupture of membrane. Contractions कम है. Okay, then artificial rupture of membrane, जिससे क्या होगा, release of prostaglandins. जैसे prostaglandin release होंगे there will be contractions बढ़ जाएंगी. So injection oxytocin. So in case of adequate contractions means यहाँ पे contractions adequate हैं, contractions are not hypotonic, then do PV, per vaginal examination. Then we will do the PV to check the cause of slow dilatation of the cervix. Then we will do the PV if the molding is present. मोल्डिंग मीन्स जो फीटल हेड है उसमें जो सूचरिंग्स होती है, हम जैसे ही पीवी करेंगे यू कैन टच द सूचर्स ऑफ द फीटल स्कल. अगर तो मोल्डिंग इज प्रेजेंट इट मीन्स यहाँ पे क्या है, सिफेलोपेल्विक डिस्प्रपोर्शन, CPD. देन डू सिजेरियन सेक्शन. Do cesarean section. Second one, if there is occipito posterior position, then wait and watch. Okay, so next one is active phase arrest. So what is the meaning of active phase arrest? Means no change in cervical dilatation even after good uterine contractions. Means 6 p.m. पे patient 3 centimeter dilated है, sorry 6 o'clock 6 centimeter dilated है, after 8 p.m. आपने चेक किया again 6 centimeter. So means there is a no change in cervical dilatation even after 4 hours with adequate uterine contractions and 6 hours with inadequate uterine contractions. Then the management will be cesarean section. Cesarean section. Okay, यहाँ पे हम wait and watch नहीं करेंगे. Active phase arrest है, then cesarean section. So next one is, so ये तो हुआ first abnormal first stage of labor. So abnormal second stage of labor. Prolonged. Prolonged means if the primary more than 2 hours and multi more than equal to 1 hours. This is called as prolonged active second stage of labor. Means no descent of head. Means head का नीचे नहीं आना with adequate uterine contractions. Means uterine contractions तो अच्छी हो रही है लेकिन fetus का जो head है वो नीचे नहीं आ रहा है. This is called as prolonged second stage of labor. So second stage starts with full dilatation of the cervix and ends with expulsion of the fetus. So then check the station of the head. We will check the station of the head. Ischial spine के levels पे हम क्या करेंगे? PV करेंगे और check करेंगे at the level of ischial spine के fetus का head का station क्या है. Okay, if the station is above +2, see, this one is the pelvis. Okay, so these are the ischial spines. 0, -1, -2, -1, -2, 0, +1, +2, +1, +2. Okay, in case 1 above +2, then do cesarean section. यहाँ पे हम वेट एंड वॉच नहीं करेंगे. बट बिलो +2, अगर तो अबव है देन सिजेरियन सेक्शन. इफ बिलो +2 देन इंस्ट्रूमेंटल डिलीवरी. You can do vacuum, you can use vacuum and या फिर forceps. Vacuum and forceps delivery, instrumental delivery. So this is all about abnormal second stage of labor. Next one is what are the components of active management of third stage of labor. So this point is important. Components of active management of third stage of labor. First one is injection uterotonic to mother after delivery of baby. Injection oxytocin for the contraction of the uterus. Second one is a delayed cord clamping more than equal to 1 minute. Third component is the delivery of placenta by controlled cord traction. And the last point is intermittent assessment of uterine tone up to 2 hours every 15 minutes. So these are the components of active management of third stage of labor. Prolonged third stage means more than equal to 30 minutes. अगर third stage को complete होने में लग जाते हैं more than equal to 30 minutes, that is called as prolonged third stage of labor. Cause क्या रहेगा? Retained placenta. Retained placenta. So next one is identify the maneuver used to deliver the head in a controlled manner in a normal vaginal delivery. एक हाथ से क्या करेंगे? We will support the perineum को support करेंगे, pushing the jar slightly upward direction and to avoid the perineal injury. साथ ही क्या करेंगे? हेड को हम एक्सटेंशन में रखेंगे कि for the delivery of the fetal head in a controlled manner. So what is the name of this maneuver? Yes, anyone? What is the name of this maneuver? in case of normal vaginal delivery. Yes, yes, Dr. Vijay. Right. Ritson maneuver. So this one is the Ritson maneuver. Ritson maneuver. So next topic is preterm labor. Preterm labor means if the labor starts before 37 weeks of pregnancy. That is called as preterm labor. So early labor means before 34 weeks. If the labor starts before 34. Early preterm means 34 weeks. Term means 37 to 42 weeks and postterm means more than 42 weeks. So how to diagnose the case of preterm labor? अब अगर आपके पास पेशेंट आता है तो आप कैसे डायग्नोज करेंगे प्रीटर्म लेबर के पेशेंट? सो फर्स्ट वन इज यूट्राइन कॉन्ट्रैक्शंस. सो more than and equal to 4 contractions in 20 minutes, and more than equal to 8 contractions in 60 minutes. Okay. And length of the cervix is less than and equal to 2 centimeters and the dilatation of the cervix is more than or equal to 3 centimeters. First diagnose, uterine contractions. Okay. Second one is funneling of internal pores. Funneling means shape of the जो cervix है T से Y shaped, then V, then U. यहाँ पे cervix है closed, in U shape में cervix is open. Cervix is open. Okay. So funneling of internal pores कैसे चेक करेंगे? By transvaginal sonography. By transvaginal sonography. And the third one, presence of fibronectin protein in cervicovaginal discharge more than 50 nanogram per deciliter. Presence of fibronectin protein in cervicovaginal discharge more than equal to 50 nanogram per deciliter. So, इस तरह से हम diagnose करेंगे preterm labor. Uterine contraction, funneling of the internal os, and the third one is presence of fibronectin proteins in cervicovaginal discharge. So, problems with preterm labor. See, अगर कोई भी fetus baby preterm labor से deliver हो जाता है तो क्या complications आए? So, lungs will not mature. Lungs mature नहीं होंगी. Then fetus को क्या होगा? Respiratory distress syndrome. Respiratory distress syndrome. And the treatment of choice is corticosteroids. Corticosteroids. Okay. And the second one is brain will not mature. Cerebral palsy. Cerebral palsy हो जाएगी. Then treatment of choice will be magnesium sulfate, which is neuroprotector. Neuroprotector. So important one is management. Management in case of preterm labor. The patient is presented with preterm labor. Okay. And the period of gestation is 32 weeks. Then we have to give steroids. So steroids should be given to all the females of preterm labor. Okay. So first one is corticosteroids. Dexamethasone for lung maturity. Dose of the dexamethasone 6 milligrams 12 hourly up to 4 doses. Up to 4 doses. And the second one is you can give metamethasone 12 milligram 24 hourly 2 doses. 2 doses. Okay. So second drug you can give tocolytic agents. Tocolytic agents क्या करेंगे? They will decrease the uterine contraction. Uterine contractions को कम कर देंगे. But कब देंगे? Before 34 weeks. If the pregnancy is before 34 weeks. After 34 weeks, no need of tocolytic agents. यहाँ पे lungs mature हो जाएंगे. And if the cervical dilatation is up to 3 centimeters. then we can give tocolytic agents. Most commonly used is nifedipine. Most commonly used drug is nifedipine as a tocolytic agents. Okay. So drug of choice in heart patients, tocolytic, that is atoxibin. या बीटा एगोनिस्ट भी दे सकते हैं जिसमें आता है रेटोड्रिन, टर्ब्यूटालिन या फिर आइसोसुप्रीन. दीज आर द ड्रग्स, बट इसमें क्या आएगा, मेटर्नल जो कॉम्प्लिकेशंस रहेंगी वो ज्यादा रहती हैं. ओके, सो प्रेफरेबली हम क्या देंगे, नेफिडेपिन. ओके, सो next topic is postpartum hemorrhage. Postpartum hemorrhage. So most common cause of primary postpartum hemorrhage. So postpartum hemorrhage means any bleeding from the genital tract of the female after the birth of the baby. Baby के birth होने के बाद अगर bleeding होती है, that is called as postpartum hemorrhage. Primary means if the bleeding occurs within 24 hours of delivery. And secondary PPH means if the bleeding occurs after 24 hours till 12 weeks of delivery. Okay, so most common cause of primary PPH, yes, atonic uterus. Atonic uterus. 80% cases में atonic uterus, most common cause of primary PPH. Okay, tell me most common cause of secondary PPH. Yes, anyone? Most common cause of secondary PPH? Secondary PPH, most common cause. Yes, Dr. Bhuwana, retained placental bits. Retained placental bits. Most common cause of secondary PPH. So, इसमें भी क्या important है? That is management of postpartum hemorrhage. Management of postpartum hemorrhage. So drugs, first one is injection oxytocin, drug of choice, 20 international unit IV infusion, not IV bolus. अगर हम IV bolus देंगे इससे क्या होगा, या तो पेशेंट को कार्डियक अरेस्ट हो जाएगा या फिर hypotension. So most commonly used drug is after delivery of the baby for the prevention of PPH, that is oxytocin. And the second, if the oxytocin is not available, then methyl ergometrin, 0.2 milligram in IM, intramuscular. But methyl ergometrin is contraindicated in, so remember the mnemonic topper. T means after delivery of the first week. O means organic heart disease. P means preeclampsia. E means eclampsia. And R means RH isoimmunization. इन कंडीशंस में हम मिथाइल अर्गोमेट्रिन को क्या करेंगे, कॉन्ट्राइंडिकेट. ओके, सो you can give oxytocin in normal saline and RL, not in DNS. Okay, so remember the mnemonic topic. Second, अगर आपको क्वेश्चन में होता है what is the drug of choice for postpartum hemorrhage, that is injection carboprost. Prostaglandin F2 alpha 250 microgram intramuscular but contraindicated in asthmatic patient. And the last drug is misoprost, prostaglandin E1, 800 microgram per rectum. So these are the drugs for the prevention and drug of choice for the postpartum hemorrhage. Okay. Again is okay. So oxytocin, methyl ergometrin, carboprost and misoprost. And surgical methods. Surgical methods are compression sutures. Name of the suture, just remember the name of the sutures. Peel-in sutures, Heyman sutures and Koskyor sutures. So these are the compression sutures. So next one-liner questions. Most common cause of shock after delivery is PPH, postpartum hemorrhage. postpartum hemorrhage. So most common cause of shock immediately after delivery is uterine inversion. Uterine inversion. Okay, and the most common cause of unexplained shock after delivery means हमें पता ही नहीं कि shock हुआ क्यों हुआ है. That is amniotic fluid embolism. Amniotic fluid embolism. So this is all about postpartum hemorrhage. Most common cause of primary PPS, secondary PPS, management of postpartum hemorrhage, and one-liner. Now questions. Most common cause of shock after delivery is PPH. Immediately after delivery is uterine inversion and unexplained shock. या तो within immediate after delivery, 15 minutes after delivery, that is amniotic fluid embolism. Next one, important maneuvers used in breech presentation. So there are 3 types of breech: complete, incomplete, and frank. So most commonly कौन सा रहेगा breech? Frank breech. So in case of extended breech means the hips are flexed and the knees are extended. Okay. So in case of extended breech, we will do groin traction. Okay, first one and the second one is Pinard's maneuver. In extended breech, Pinard's maneuver, pressure on the popliteal fossa. Pressure on the popliteal fossa, जिससे क्या होगा? Flexion of the knee. जैसे knee flexion होगी, then hold the legs and baby out. So this is called as Pinard maneuver. In case of extended arms, अब बेबी की ट्रंक तो डिलीवर होगी, लेग्स, बटक्स, ट्रंक सब डिलीवर हो गया. अब हम यहाँ पे क्या रह गया? एक्सटेंडेड आर्म्स. सो मोस्ट कॉमनली यूज मैनूवर इज Lovesett's maneuver. Rotation of the fetal body so that the anterior shoulder becomes posterior and hold the arm and pull it out. That is called as Lovesett's maneuver. After coming head आपको याद रखने हैं 2 maneuvers. First one is Bern-Marshall's maneuver. Okay. Suprapubic pressure and flexion of the head. Bern-Marshall maneuver. This was the Bern-Marshall. And the second one is Maris's smiley weight maneuver. Just suprapubic pressure and right hand on the head of the fetus for the flexion of the, जिससे क्या होगा? Flexion of the head, and the lower left hand से क्या करेंगे हम? On the mouth, fetus के माउथ पे यहाँ पे रखेंगे, जिससे क्या होगा? हम एक तरह से flexion of the head करेंगे और fetus को head को out कर लेंगे. That is called as Maris's smiley weight maneuver. Okay. So third one, best one is the Piper's force. So please remember, in case of extended breech, groin traction, Pinard's maneuver, just remember the name of the maneuvers. Okay. Extended arm में Lovesett's maneuver. After coming head, Bern-Marshall's maneuver, Maris's smiley weight maneuver, and Piper's forceps. So I think breech presentation में यही important है. Next one is the shoulder dystocia. So in case of shoulder dystocia, इसमें होगा क्या? Difficulty in the delivery of the shoulder of the fetus. Mean head तो deliver हो गया लेकिन shoulder deliver नहीं हुए. That is called as shoulder dystocia. Management में just remember the mnemonic helper. So H means call for help. अगर shoulder dystocia है, then you can't manage the patient. आप अकेले मैनेज नहीं कर पाएंगे, क्योंकि अगर shoulder की डिलीवरी नहीं होगी, then क्या होगा? चेस्ट कंप्रेशन हो जाएगा, कॉर्ड कंप्रेशन हो जाएगा, fetal hypoxia हो जाएगा. Okay, so call for help. E means episiotomy. To get more space, episiotomy करेंगे तो आपको क्या होगा और space मिल जाएगा for the delivery of the shoulder of the fetus. L means legs maneuver. Mac-Roberts maneuver. This is the first maneuver जो हम करते हैं in case of shoulder dystocia. Pressure externally. Then suprapubic pressure. Suprapubic pressure. E means enter and rotational maneuvers. कौन से होंगे? Rubin's maneuver and Woodcock-Crew maneuver. Okay. And R means remove posterior arm and the roll over onto all fours. Gaskin's maneuver. So this is the management of shoulder dystocia. This one is the Mac-Roberts maneuver. Mac-Roberts maneuver means hyperflexion of the maternal thighs. लेग्स को इतना हाइपर फ्लेक्शन कर देंगे जिससे क्या होगा, यू कैन सी क्लियरली इन दिस इमेज, दिस इज अ सेक्रम. जैसे ही आपने हाइपर फ्लेक्शन किया टुवर्ड्स द मैटरनल एब्डोमेन, यू विल सी pelvic tilts upwards. Pelvic tilts upwards is this is the angle. It will tilts upward direction में. इससे क्या होगा, सेक्रम हो जाएगी फ्लैट, स्ट्रेट. Then anterior shoulder slips out. Anterior shoulder slips out. So this one is the Mac-Roberts maneuver. Then अगर इससे भी डिलीवरी नहीं होगी shoulders की, then suprapubic pressure. Next step will be suprapubic pressure. So this is all about shoulder dystocia. And the next topic, important one, is anemia in pregnancy. Anemia in pregnancy. So most common cause of anemia in pregnancy in India. Yes, anyone? Most common cause of anemia in pregnancy in India. Dr. Bhavana. Iron deficiency is the most common cause of pathological anemia. That is iron deficiency anemia. Iron deficiency anemia. Yes, Dr. Ritvik. Most common cause of anemia in pregnancy in India is nutritional anemia. Nutritional anemia. मदर को न्यूट्रिशन पूरा नहीं मिलेगा तो फीटस को कहां से मिलेगा? ओके. एंड द मोस्ट कॉमन एनीमिया इन प्रेगनेंसी इज फिजियोलॉजिकल. देन आयरन डेफिशिएंसी एनीमिया. ओके. सो फिजियोलॉजिकल एनीमिया क्यों होगा ड्यूरिंग प्रेगनेंसी? बिकॉज ऑफ हीमोडाइल्यूशन. सो फिजियोलॉजिकल में एचपी हमेशा रहेगा more than 11 grams. ऐसा नहीं कि हीमोग्लोबिन 11 ग्राम से फॉल करे in case of physiological anemia, but in case of iron deficiency anemia, hemoglobin fall कर जाएगा less than 11 grams. So physiological anemia is mainly due to hemodilution. Hemodilution क्यों होगा? Because of, देखो, ब्लड वॉल्यूम बढ़ेगा ड्यूरिंग प्रेगनेंसी. फिजियोलॉजिकल चेंजेस में ब्लड वॉल्यूम बढ़ेगा, प्लाज्मा वॉल्यूम बढ़ेगा. ओके. और फ्लूइड रिटेन होगा बॉडी. सो बिकॉज ऑफ हीमोडाइल्यूशन पेशेंट को क्या हो जाएगा? फिजियोलॉजिकल एनीमिया. सो अकॉर्डिंग टू WHO, anemia in pregnancy if the hemoglobin is less than 11 grams. Severe anemia means hemoglobin less than 7, and very severe anemia means less than 4 grams. Less than 4 grams. And the daily requirement of iron in pregnancy is 4 to 6 milligrams per day. 4 to 6 milligrams per day. So next one is the management of anemia. If mild to moderate anemia, less than 34 weeks, then give iron tablets, 2 tablets per day. 2 tablets per day. More than 34 weeks in third trimester. अगर यहाँ पे तो हम आयरन टैबलेट्स इतनी नहीं दे पाएंगे बिकॉज कभी भी डिलीवरी हो सकती है, देन आईवी आयरन, आईवी आयरन. ओके, सो लेस देन 34 वीक्स 2 टैबलेट्स पर डे. हमें हीमोग्लोबिन का टारगेट कितना चाहिए? 11 ग्राम्स, मोर देन 11 ग्राम्स. आफ्टर 34 वीक्स आईवी आयरन. ओके, आईवी में हम कौन सी दे सकते हैं? या तो जेक्टोफर आता है या आयरन सुक्रोज दे सकते हैं. ओके, सो in case of mild to moderate, but in case of severe anemia, so in case of severe anemia, if the hemoglobin is 5 to 7 grams, less than 34 weeks, IV iron, more than 34 weeks, blood transfusion. Then we have to give blood transfusion. Okay, but if the hemoglobin is less than 5, then blood transfusion. Then blood transfusion. So clear to all of you in case of mild to moderate and severe anemia management. So next one important topic is anticoagulants in pregnancy in case of heart patients. So mostly normally हम जो patient को देते हैं that drug is warfarin, but during pregnancy in first trimester warfarin is contraindicated. This one is a strong anticoagulant, teratogenic, can cross the placenta. अगर ये placenta को cross कर जाए अगर first trimester में हम देने, then it will lead to CNS defects and cartilage defects. Okay, so up to 12 weeks. Up to 12 weeks. So up to 12 weeks, if the dose of warfarin, if the patient पहले से ही warfarin ले रहा है, if the dose is less than 5 milligrams per day, then we can continue warfarin. कितना less dose है तो हम warfarin दे सकते हैं, or we can change the drug, or you can give low molecular weight heparin. Low molecular weight heparin. Okay, so if the patient is taking warfarin more than 5 milligram per day, then stop the warfarin. यहाँ पे हम warfarin stop कर देंगे and give heparin. Low molecular weight heparin. Okay, so up till 12 weeks मैंने आपको बताया. If the patient is taking already ले रहा है warfarin less than 5 milligrams per day, या तो हम warfarin को continue रखेंगे या फिर हम क्या करेंगे, switch over to lower molecular weight heparin. If the dose is more than 5 milligram per day, then यहाँ पे हम warfarin को stop करेंगे and heparin start करेंगे. Okay, so after 12 weeks to 36 weeks, you can give warfarin. warfarin दे सकते हैं. 36 weeks till onset of labor, low molecular weight heparin. Okay, and 3 days before expected date of delivery, again shift to heparin. Heparin. Or okay, so this is the dose of anticoagulants in heart patient in pregnancy. Okay, तो रीस्टार्ट एंटीकोगुलेंट, हम एंटीकोगुलेंट्स को कई बार क्वेश्चन आता है कि रीस्टार्ट कब करेंगे. ऐसा तो नहीं है कि हम वारफरिन या हेपरिन को स्टॉप कर देंगे. ओके, सो आफ्टर डिलीवरी, आफ्टर वेजाइनल डिलीवरी, यू कैन स्टार्ट वारफरिन आफ्टर 6 hours, after 6 hours, and after cesarean section after 6 to 12 hours, after 6 to 12 hours. You can start warfarin. You can start warfarin. So next topic is teratogenic infections in pregnancy. Teratogenic infections in pregnancy. Teratogenic infections in pregnancy. So इस पे इम्पोर्टेंट जस्ट क्या है कि मैक्सिमम रिस्क ऑफ वर्टिकल ट्रांसमिशन कब है एंड मैनिफेस्टेशंस क्या है. ओके, सो फर्स्ट वन इज साइटोमेगालोवायरस, CMV, cytomegalovirus, CMV. And this virus is a DNA virus. This is a DNA virus. तो कई बार क्वेश्चन क्या आता है कि मैक्सिमम रिस्क ऑफ वर्टिकल ट्रांसमिशन कब हो. ओके, सो इन केस ऑफ CMV थर्ड ट्राइमेस्टर में क्या होगा, मैक्सिमम रिस्क ऑफ वर्टिकल ट्रांसमिशन.
So problem with the video is not showing. So we can take a break of 2-3 minutes. Faizan, explain to you. Announce announce regrets for corruption.
Okay, just which one that's break.
PhD. Started.
So let's start with the topic of teratogenic infections in pregnancy. So first one is CMV, cytomegalovirus, and this virus is a DNA virus. So maximum risk of vertical transmission in third trimester. In third trimester. So mostly asymptomatic. Mostly asymptomatic. And most severe before 20 weeks. Most severe before 20 weeks. So manifestation क्या होगा in case of CMV infection? So it will lead to congenital CMV syndrome. अगर किसी मदर को CMV infection है, अगर इसका vertical transmission होता है to fetus, then it will lead to congenital CMV syndrome. And this one is the most common congenital cause of sensory neural hearing loss. SNHL, sensory neural hearing loss, and periventricular calcifications and microcephaly. Just remember the 3 points: SNHL, periventricular calcification, and microcephaly. And there is a no vaccination and no treatment for CMV in pregnancy. So, आपको याद कर रखना है, maximum risk of vertical transmission is third trimester. This infection is mostly asymptomatic. Flu-like symptoms होंगे mother को, and most severe infection before 20 weeks. And this leads to congenital CMV syndrome. Most common congenital cause of sensory neural hearing loss, periventricular calcification, and microcephaly. So next one is toxoplasma. Next one infection is toxoplasma. So causative agent is Toxoplasma gondii. Maximum risk in third trimester. 80 to 90% cases are asymptomatic. Most severe infection occurs in first trimester. Okay. So इसमें क्या manifestation मिलेंगे हमें? Intracerebral calcifications and hydrocephalus. Intracerebral calcifications and hydrocephalus, and the drug of choice. Drug of choice, spiramycin. Spiramycin. Drug of choice का रहेगी मदर के लिए spiramycin. Yes, डॉक्टर भुवाना, कैट फीसिस. अगर जो कोई फीमेल अगर कैट्स के कांटेक्ट में रहती है तो ड्यूरिंग प्रेगनेंसी चांसेस रहते हैं टॉक्सोप्लाज्मा होने के. सो कैट से दूरी रहें. सो ड्रग ऑफ चॉइस इज स्पाइरामाइसिन. सो नेक्स्ट इंपॉर्टेंट वन इज रूबेला infection. So this is a RNA virus and most teratogenic. सबसे जो ज्यादा teratogenic infection है, that is rubella infection. Maximum risk of transmission in first trimester. 25 to 50% asymptomatic and most severe fetal defects कब होंगे? Up to 16 weeks. So please remember, first trimester, most commonly vertical transmission कब होगा? In first trimester. अगर मदर से इंफेक्शन जाता है फीटस को, then it will lead to congenital rubella syndrome in 90% cases. क्लियर टू ऑल ऑफ यू? अगर रुबेला इन्फेक्शन होता है फर्स्ट ट्राइमेस्टर में, देन इट विल लीड टू कॉन्जेनाइटल रुबेला सिंड्रोम इन 90% केसेस. सो इसीलिए जब भी प्री काउंसलिंग होती है, प्रेगनेंसी, कोई कपल है वो प्रेगनेंसी चाहते हैं, तो हम क्या चेक करवाते हैं? रुबेला एंटीबॉडीज. ओके, इफ द पेशेंट इज इम्यून, ऑलरेडी इम्यून है, देन नो प्रॉब्लम. ओके, इफ शी इज नॉट इम्यून, देन हम यहाँ पे देंगे MMR का इंजेक्शन फीमेल को, एंड प्रेगनेंसी विल बी कॉन्ट्राइंडिकेटेड अप टिल 1 month. ओके, ड्यूरिंग प्रेगनेंसी हम इंजेक्शन नहीं दे पाएंगे बिकॉज दिस इंजेक्शन इज ए लाइव इंजेक्शन. ओके, सो कॉन्जेनाइटल रुबेला सिंड्रोम में क्या मिलेगा? डेफनेस, कैटरैक्ट एंड हार्ट डिजीज. हार्ट डिजीज हमें सिर्फ मिलेगी इन केस ऑफ रुबेला सिंड्रोम, कॉन्जेनाइटल रुबेला सिंड्रोम. Yes, PDA rubella. Yes, Dr. Bhuwana, PDA rubella and SNHL, sensory neural hearing loss. So, अगर किसी fetus को होता है congenital rubella syndrome, then it is an indication for MTP. So please remember, this is the most common teratogenic infection in pregnancy. अगर मदर को हुआ है तो 90% चांसेस है को फीटस को भी होगा. सी यस, 25 to 50% केसेस में ये एसिम्टोमेटिक रहता है. ओके, बट अगर इंफेक्शन मोस्ट सीवियरली कब होगी? 16 वीक्स पे. अगर 16 वीक्स तक इंफेक्शन होता है, चांसेस है कि 90% क्या होगा? कॉन्जेनाइटल रुबेला सिंड्रोम. So next one is parvovirus B19. This one is a DNA virus which replicates in erythroblast precursors, causing anemia in fetus. And maximum risk of transmission in second trimester, most severe between 13 to 16 weeks. So this is a cause of, अगर किसी फीमेल को parvovirus B19 है and इसका ट्रांसमिशन हुआ है फीटस में. ओके, इसमें कोई किसी तरह का फीटल डिफेक्ट नहीं होगा. इसमें क्या होगा? या तो अबॉर्शन हो जाएगा, स्टिल बर्थ, फीटल एनीमिया, नॉन इम्यून हाइड्रॉप्स फिटालिस मोस्ट कॉमनली. सो मोस्ट कॉमन कॉज ऑफ नॉन इम्यून हाइड्रॉप फिटालिस इज parvovirus B19 and doesn't lead to any fetal birth defects. So target scan करेंगे every 2 weekly to check the fetal anemia. PSP of the MCA, peak systolic velocity, peak systolic velocity of middle cerebral artery, then check for anemia. Check for anemia. See, जब भी हमने fetus में anemia check करना है, then we have to do PSP of middle cerebral artery. Okay. So next one is varicella zoster, DNA herpes virus, maximum. Yes, Dr. Faisal. In case of parvovirus हमें क्या साइन मिलेगा? स्लैप चिक रैश. दोनों गालों पे क्या होगा? रैश रेड कलर की हो जाएंगे फीटस की. यस. So in second trimester, maximum risk of transmission in second trimester, most severe between 13 to 20 weeks. Okay. Manifestation is congenital varicella syndrome. अगर इन्फेक्शन होता है मदर को और ट्रांसमिशन के चांसेस रहेंगे 13 to 20 weeks, then it will lead to congenital varicella syndrome. हमें इसमें मिलेगा स्किन स्कारिंग, microcephaly, limb deformities. Please remember, limb deformities are seen in congenital varicella syndrome and cataract. And drug of choice will be acyclovir. Drug of choice will be acyclovir. अगर मदर कांटेक्ट में आती है किसी इन्फेक्टेड पर्सन के, then we have to give varicella zoster immunoglobulin to the mother. Okay, अगर मदर को इन्फेक्शन हो जाता है then drug of choice will be acyclovir. So this one is the important point. So let's see. So if the delivery occurs 5 days before to 2 days after delivery, if the infection occurs 5 days before to 2 days after delivery, okay, then it will lead to neonatal varicella syndrome. So इस टाइम पे विजाइनल डिलीवरी को अवॉइड करना चाहिए. अगर इस टाइम पे मदर की नॉर्मल डिलीवरी हो रही है देन चांसेस ऑफ नियोनेटल वेरिसेला सिंड्रोम बढ़ जाएंगे. देन आफ्टर डिलीवरी गिव वेरिसेला जोस्टर इम्यूनोग्लोबुलिन टू न्यूबॉर्न इमीडिएटली, जिससे क्या हम प्रिवेंट कर सकते हैं कि इन्फेक्शन ज्यादा ना हो. ओके, एंड व्हाट आर द क्लिनिकल फीचर्स? pneumonitis, hepatitis and meningoencephalitis. So just remember the maximum risk of vertical transmission, manifestations and treatment of infections. So next topic, just quickly revise करते हैं इसको भी, placental abnormalities. So first one is the placenta subcensurate. A small lobe of placenta is separated from the main lobe. Small lobe of placenta separated from main lobe. आप देखेंगे यहाँ पे, this one is the placenta और ये क्या है? Small lobe of placenta. ये separate हो जाएगा, but remains connected with blood vessels. Remains connected with, आपस में क्या रहेंगे? Connected रहेंगे. So this is called as placenta subcensuate. And the complication क्या होगी? Postpartum hemorrhage. Main placenta तो out आ जाएगा, जो छोटा पार्ट है वो अंदर रह जाएगा. So postpartum hemorrhage and infections. Next one is the Battledore placenta. This one is a Battledore placenta. Means cord attached to the margins of the placenta. To the margins of the, normally cord attachment क्या होगा? Center of the placenta. Normally center of the placenta cord. But यहाँ पे cord कहाँ है? Margins of the placenta. Lateral side of the placenta. So complications इसमें क्या रहेंगी? Cord avulsion, bleeding. जैसे प्लेसेंटा का आउट करने लगेंगे क्या होगा? कॉर्ड इंजरी, ब्लीडिंग एंड फीटल डिस्ट्रेस एट द टाइम ऑफ डिलीवरी. फीटल डिस्ट्रेस, जैसे बेबी डिलीवर होगा कॉर्ड खिंच जाएगी, जिससे होगा कॉर्ड इंजरी, ब्लीडिंग एंड फीटल डिस्ट्रेस. नेक्स्ट वन इज द वेलामेंटस इंसर्शन ऑफ कॉर्ड. वेलामेंटस इंसर्शन ऑफ कॉर्ड. Insertion of cord means cord is first attached to membranes. membranes के साथ then will attach to the placenta. उसके बाद attach होगी placenta को. In this image you can see cord is attached to the membranes. placenta में ना attach होके membranes को attach होंगी. Okay, so cord is first attached to membranes and to placenta. जैसे ही at the time of labor, जैसे ही membranes rupture होंगी, then it will lead to cord injury, fetal loss. cord injury जिससे क्या होगा? fetal blood loss, fetal distress, and this is called as vasa previa. So this is called as vasa previa. So vasa previa में किसमें मिलेगा? Velamentous insertion of cord. Next one, circumvallate placenta. इसमें आप देखेंगे this one is the fetal surface side of the placenta which is smaller than the maternal side of the placenta, and there is a presence of thick wall at the junction of maternal and fetal side. Okay, evolve like thickness present at the junction of fetal surface, fetal and maternal surface. Fetal surface is smaller and less blood goes to the fetus. अगर fetal surface small होगा तो fetus में कम blood जाएगा. Then it will lead to IUGR, intrauterine growth restriction and abruptio placenta. So these are the complications of circumvallate placenta. So अभी हम पढ़ रहे हैं abnormalities of placenta. So next one is morbidly adherent placenta. Means due to the absence of neta bush layer. अगर neta bush layer नहीं होगा, then villi further penetrate into myometrium. Normally जो trophoblastic या villi है ये penetrate करेंगे up to the endometrium. Okay, so if they penetrate into the myometrium, that is called as morbid adherent placenta. So types, first one is acreta. Acreta means placenta is attached superficially to the myometrium. That is called as acreta. Superficially attached to the myometrium. Increta means villi are present. Placenta implant हो जाएगा into the myometrium. Myometrium के अंदर तक चला जाएगा. In case of this one is the second, third one is the percreta. Percreta means placenta will penetrate the myometrium. Myometrium को पूरा penetrate करते हुए कहां तक चला जाएगा? Serosa of the uterus. This one is the serosa of the uterus. Type 3. So acreta, increta and percreta. Per means पार चला जाएगा यूट्रस के. Increta means inside the myometrium. Acreta means superficially attached to the myometrium. So presentation, patient के presentation क्या रहेगा? Postpartum hemorrhage. Baby तो deliver हो गया, but we will not able to remove the placenta. So postpartum hemorrhage and persistent bleeding after delivery. Persistent bleeding after delivery. So investigation of choice is ultrasound with or without Doppler. And the gold standard is MRI. Gold standard is MRI. So this is all about morbidly adherent placenta. So next one is used for diagnosis of pregnancy by manual examination. Lower part of the uterus becomes soft. Abdominal and vaginal fingers seems to be approximate each other. Means we are doing PV per vaginal examination. Okay, so यहाँ पे वन हैंड हमने रखा है प्यूबिक सिम्पाइसिस के ऊपर एंड फील कर रहे हैं यूट्रस के लोअर पार्ट ऑफ द यूट्रस को. एंड क्या फील हो रहा है? एब्डोमिनल एंड वेजाइनल फिंगर्स सीम्स टू बी अप्रॉक्सीमेट टू ईच अदर. सो व्हाट इज द साइन? कौन सा साइन है यूज फॉर द डायग्नोसिस ऑफ प्रेगनेंसी? यस, diagnosis of pregnancy. Use for diagnosis of pregnancy. Name of the sign. Haggard sign. This one is the Haggard sign. Dinesh, Goodell sign is the softening of the cervix. Yes. but this one is a Haggard sign. Haggard sign. Yes, Dr. Vicky, right? Haggard sign. Okay. So next one is only indication for internal podalic version is. कौन सी कंडीशन है? Only indication for internal podalic version. Done in OT under general anesthesia, absolutely contraindicated in previous cesarean section. So only indication for internal podalic version is this one is the transverse lie of the fetus, not cephalic. Yes, twin pregnancy. Twin pregnancy में if the first baby is cephalic presentation and the second one is transverse lie, so only indication for internal podalic version is transverse lie, transverse lie of second twin. Second twin. Okay. So transverse lie of second twin. Internal podalic version. It means आपने क्या किया यहाँ पे? बेबी के पैरों को लिया, पकड़ा और घुमा के इसको क्या किया? ब्रीच एक्सटेंशन कर लिया, ब्रीच पोजीशन में निकाल दिया. दिस इज कॉल्ड एज इंटरनल पोडालिक वर्जन. नेक्स्ट वन, आइडेंटिफाई द नेम ऑफ द मैनूवर्स. Identify the name of the maneuvers. Leopold, yes. Which one? Leopold maneuver. First one is Pollock grip. Pollock. Leopold. Pollock grip. Yes, third maneuver, Pollock grip. Third. And the fourth one is deep. Fourth one is deep pelvic grip. Deep pelvic grip. Fourth one is deep pelvic grip. इन दोनों ही लियोपॉल्ड में हम क्या चेक करेंगे? हेड एंगेज हुआ है या नहीं हुआ. सो इन केस ऑफ सेकंड थर्ड ग्रिप, जस्ट वी विल चेक द जस्ट वन हैंड से हम चेक करेंगे कि फीटस का हेड एंगेज हुआ है या नहीं हुआ है. इन द फोर्थ वन इज द पॉली ग्रिप. इसमें भी हम दोनों हाथों को क्या करेंगे? इंग्वाइनल रीजन में रखेंगे, चेक करेंगे कि फीटस का हेड एंगेज हुआ है या नहीं हुआ. सो देयर आर 4 types of Leopold maneuver. First one is fundal grip. Fundal grip. Second one is lateral grip. Lateral grip. Third one is Pollock grip. And the fourth one is deep pelvic grip. Okay. So this one, the last topic. So I think I've almost finished the important topics of obstetrics. So thanks to all of you. My next session of gynecology will be on, I think, 8th of June. 8th of June, gynae. Okay. So we'll try to cover all the topics of gynae. Okay. So wish you all the best for your exam. And thanks for being with us. Thank you to all of you. इसमें एक क्वेरी थी कि मैम अगर कॉरियोनिक विलाई सैंपलिंग ले रहे हैं तो हमें डोज ऑफ द एंटीडी कितना होना चाहिए, देन डोज इन केस ऑफ कॉरियोनिक विलाई सैंपलिंग RH नेगेटिव मदर, द डोज होना चाहिए 50 माइक्रोग्राम्स, 50 माइक्रोग्राम्स ऑफ इंजेक्शन एंटी डी. So much.
Say something to the students.